Bwrdd croeso, welcome to this morning's public board, the Bwrdd University Health Board. I'm delighted to see everybody here, one or two new faces, which is always great to see around the table. We have a fairly lengthy agenda and quite a lot of substantive items to look at and address as part of the meeting. Before we begin, I just need to cover off a few governance issues in my head to make sure that it's a productive and worthwhile meeting. Can I ask if all members received the papers in good time? All 1,400 pages of them? Great. Plenty of time for reading, plenty of reading. Were the papers clear and comprehensive? Did they cover the issues that you would have wanted them covered? Obviously, this is an opportunity for us to be able to quiz and question authors and supporters and sponsors of papers, but did you feel there was enough in the papers for you? Great. And is there anything that we felt might have been omitted or wasn't in the papers, or something that we should discuss that's not on the agenda? Chantal?
I think it's just that there was a lack of narrative around some of the papers that are, in particular in terms of the finance papers, so that we can have an understanding how well we are dealing with those urgent matters at an operational level. So perhaps adopting a narrative around the way in which the papers are presented might be helpful.
Great. Well, let's take that as we approach each of the papers to see whether that's the case or not, and what we might do about it. But thank you for that feedback. As ever, I think it's really important. This is a decision-making board. It's also an endorsing board, and a board that needs to be assured of the work of the health board. But it is fundamentally a decision-making board. It's where probably we're able to bring most value to the organisation. And for me, what's really important is that we are consistent in the way in which we make decisions, and that at each board we operate the same broad design principles in the way in which we make our decisions. And that's partly for us to ensure that we are being robust and scrutinous in our approach, but it's also to ensure that the public have confidence in the way in which we're trying to make our decisions, and that we are balanced and fair in our approach. So just to remind you of those decision-making principles, fundamentally our decisions must be driven by being fair. So we need to ensure that at all times they're fair. They are affordable and sustainable. So we cannot afford to make decisions that actually result in the unsustainability of the health board or are not affordable in the long term. We need to ensure our decisions are consistent with our strategic approach. Many of these decisions may be operational and be focused on actions we need to take now and in the near future, but they must align with our direction of travel in terms of where we think we need to be arriving at some point in the future. They need not to create an unhelpful precedent. So what we don't want to do is make a decision which then has wider implications or will require us to make a similar decision in other circumstances that might not be appropriate or helpful. So for me, it's about not creating an unhelpful precedent. And then probably last but not least is the importance of making decisions that are about clinical safety and quality. So we at all times, we must be risk aware of the potential for the decisions we make to have an outcome or a result that could impact upon the safety or clinical quality of the services for which we're responsible for delivering. Is everybody clear on that? Great, okay, thank you. Let's move to apologies. Oh, well, actually, yes, so...
Sorry, Chair, so we've got apologies from Mr Mark Henwood, and he's been represented by Dr Irene Edmonds today. And we've also got James Severs, who is on the Zoom because he's not very well today either, Chair.
Great, okay. Sorry to hear that.
And we've got Ewan Thomas, independent board member as well. Great.
Sorry to hear you're unwell, James. I hope you recover quickly. Welcome, Irene. It's great to see you again. And I think also we've got Trina.
Yeah, she'll be supporting one of the items on the agenda, the wellbeing objectives.
That's Trina Nealon, the Principal Public Health Officer. Welcome. Great, okay. Let's move to declarations of interest. Are there any declarations of interest? Or yes, please.
Yeah, on item 6.4.2, the digital transformation strategy, part of the evaluation team evaluated these.
Thank you, Maynard. We will bear that in mind if we could record that. We may want to call upon your view as part of that conversation there. Any other declarations of interest or conflicts that people anticipate? Or yes, please, Anne.
It's the clinical service plan. There may be some conflict as I'm a trade union representative, as an IM. So there's feedback from some of the staff that are unhappy, but so I might have to just overview it. So I declare an interest in that.
Great, okay. I mean, fundamentally, we would see the kind of transformation of people and roles to be significant in relation to the clinical services plan. So that is a really important element of what we're trying to deliver in this space. So we welcome your thoughts and views on that matter as well. Thank you. Great. If that's it, let's move on to preliminary matters. And first and foremost, minutes of the public meeting held on the 26th of September 2024. Are members of the board comfortable with the minutes? Anything that's missing or inaccurately represented? No? No. Great, okay, let's accept the minutes as a true record. If we could move to the matters arising and table of actions.
Chair, may I raise one point on the PM 24188 in terms of the strategic quality plan? Just to say that we have got a board seminar session planned on the 15th where we'll be working through that as a request of the board. But I know there was a specific ask in terms of a task and finish group, so I'm not sure if Lisa or Anna could just add slightly where we are with that, Chair.
Thank you. Lisa.
Yeah, diolch. We have the board seminar. We've had some preliminary meetings with Anna's support, and the outcome is that once we've had the seminar, discuss the issues, we'll then be setting up the task and finish group. So everything's in place, ready to enact after the seminar. Great,
okay. And Anna, you're comfortable with that? Thank you. I think, as I said at the last meeting, it's an area where we need to show some serious progress on and understand to a much greater degree than we do currently. So I welcome your involvement and the task force picking that up. And I'm hoping the working group, when we meet in December, we will have more clarity over what we're trying to inquire into as part of that work. Very good. Okay. Any other issues relating to matters arising? Yes, please.
I mentioned just one thing. At the last board meeting, we discussed Pendrawell and Picton Terrace. You'll recall they came up in conversations just to advise board members that since the last meeting, we've had confirmation of capital funding from Welsh Government to support both of those developments. Thank you.
Great. Okay. Thank you very much, Lee. My only other observation would have been in relation to the paediatric and inpatient provision at Bronglais Hospital. Just for my understanding, I'm presuming that this is being kind of monitored and scrutinised through the Quality, Safety and Experience Committee.
Yes, Chair.
Great. Okay.
Sorry, I'm not the chair, sorry.
Yes, that's correct. And we have our meeting coming up next week where we'll be looking at this in detail for the first time.
Great. Okay, that's given me some assurance around that. Sharon, you're comfortable with that too?
I am, thank you, Chair.
Okay, I'm really sorry. I have to leave for the time being, just for a short call. Eleanor, can you?
Can indeed, yes.
Sorry about that.
Sorry, Chair.
The matters arising and table of actions from the meeting.
Before we continue, can I just ask all members, we're getting feedback from members of the public they can't actually hear, other than Neil at the moment, so can you move your microphones closer to you and speak a little bit louder when you're presenting? Thank you.
Thank you very much, Joe. So we move now to the matters arising and the table of actions that we would take any comments on from everybody?
If we're looking at the table of actions, just 178, I just wonder, has been raised with RPB chair. Is that working? Has there been any feedback on that? So it's a minute reference, PM 24178.
Yes, thank you. Yes, it's been raised with RPB chair in the sense of highlighting that it does need some regional partnership board consideration and discussion with the Welsh Government. There has been, coincidentally, not because of that action, but because it has been prioritised earlier, a workshop which was held end of October as part of the Regional Partnership Board, in which Welsh Government were present, and we will be getting, as the Children and Young People Board of the RPB, will be getting the feedback from that workshop, and we'll see how we can escalate or support any further.
Thank you.
Thank you, diolch. Any other comments on the table of actions? If not, we'll take them as read and move on. And our next item is the minutes of the corporate trustee meeting held on the 26th of September. Any comments on that paper, please? I'm going to take it that you've all read them. And if not, we shall move on. Thank you. Matters arising from the corporate trustee meeting then. We had 2 items on there. Are there any comments on those? No? Thank you very much. Minutes then of the AGM held on the 26th of September. To be noted, I was absent from that meeting, so I'm expecting comments from others who did attend, please. Gosh.
Chair, to note that the minutes have been circulated in advance, and if there are any comments or corrections have been made prior to board approval today.
Okay. Diolch yn fawr. Moving on then to the Chair's report.
Do you want to, should we skip the Chair's report until?
I think that's probably a good idea, and move on to the Chief Exec's report, and I'll hand it over to you, Bill.
Thank you.
And probably worth saying, it's your first board since being appointed, so congratulations on being appointed Chief Executive of Hywel Dda.
Diolch, Eleanor. So delighted to be appointed as substantive Chief Exec and working with you all in the longer term for the benefit of our population to improve services, attempt to improve the health and well-being of our population, working with all of you, our partners and our communities. So I'm really energised and excited at that prospect, and of course have enjoyed working with you over the last 8 or 9 months as an interim Chief Exec. So there are a number of important matters in the Chief Exec's report. In the report there are some of the items where there's a more substantive item later on in the agenda. So one of those is I would call out is our Healthier Mid and West Wales strategy update. There's a strategy paper later on in the board, so we can take some questions on that now, but I suspect that some of those questions might be linked to the paper later on. I did want to highlight the petition that we received with 10,031 signatures relating to Prince Philip Minor Injuries Unit. We will consider that carefully as part of our conscientious consideration of all the feedback that we get around the minor injuries unit, and it will be part of our process that we follow, and there is a paper later on the agenda related to Prince Philip. I'll come back to St David's, if that's okay. There's also important updates on Tregaron and on the paediatric change that we made at Bromgleis Hospital. The change at, you'll see, first of all, Tregaron that there's quite a lot of detail about how we're managing that change and how we're working with staff on the sort of transition and the sort of potential positive benefits that we think we will see from that change. In terms of paediatrics, the change was made on the 18th of November, as indicated in the board paper. And however, you'll see also in the board paper that there are some hope around. There is some hope around the recruitment of paediatric nurses, and we'll be reviewing the situation in January and testing that early at the new year to see if we can revert back to the original service earlier than we suggested. But of course that will be very much dependent on having the staff with the right skills in place. And as we've heard earlier, that the quality safety aspects of these changes will be monitored through Quality and Safety Committee. The other area to draw attention to is the planned care allocation. We were really grateful to receive that additional allocation from Welsh Government, and it will allow us to treat more patients this year than we would have been able to do, which I think is great news, because we do, of course, have people waiting far too long for our elective services. So we're working on that. Just to highlight one point in the last couple of paragraphs there, that it's possible that we may need to have a chair's action meeting in between this board and the next board to agree the contracts necessary to undertake that work. And the only other item I did want to highlight, and I'll hand over to Jill on this, is our progress on St David's surgery and our some of the feedback that we're getting from the public and our sort of engagement with the public.
Thank you.
I think it's really positive to say that since the last board meeting, we did open as planned. So the signs went up at the end of October for Meddygfa Penryn, and both the main site in the previous former Solva building and the branch surgery at Shalom opened on time. And we've had very positive feedback from patients who are very grateful actually for the facilities that we've got at Shalom. So I want to say thank you again to the trustees of Shalom for working with us to develop that. We've got the ongoing building works that are taking place in the main former Solva surgery building, but we have opened up now a new clinical room and a new treatment room, and we've got some work to finish around the reception area. But again, the building contractors have been very considerate actually in terms of the way in which this work has progressed whilst we've continued to see patients. And as always happens when we transfer patients into a surgery, there's a lot of catch-up work now on chronic conditions management reviews, medication reviews, and patients are being seen in a timely way to ensure that that works forward. And again, of course, work to bring the two workforce teams together. I think the important bit that I'd want to reflect, as you did mention there, Phil, was the issue around the ongoing communication and engagement. And we've got the working group and the stakeholder group, which are both very active, ongoing, to look at that future model for our peninsula. But we've had recent feedback, again, that is going to be important when we get to the primary care governance paper as well, so that we're always mindful of the process that we follow to make sure that we've got the right membership, the right ongoing engagement and communication in terms of the way in which we make decisions. And so I just want to emphasise the work that we continue to do with our public and our community around the St David's area, but it's something that we want to reflect in all the decisions that we make going forward. And I think, Chair, you set out some of those principles at the beginning to make sure that we've got those right principles and that the decisions then that the board make are appropriately and properly informed by our community. So I'd like to pick up the main issues around the primary care governance paper when we get there, but I just wanted to reflect the issue that has been brought to our attention, that there was an issue that people felt was important to reflect in terms of making sure we've got that right membership and communication in our process and how we work there. But I do want to assure the board and members of the public that we've got the ongoing work to look at the future of Myddek Penrhyn, and it does engage various stakeholders who are very active actually in helping us to think about the future, and it's an exciting time for us to be able to do that, and fits very well with the item that we'll be considering as well on the Healthier Mid and West Wales. So it's really part of our strategy and how we think about the delivery of services for the future. So thank you.
Thank you, Jill, and croeso nôl Cadeirydd. We left your paper for you to present, your chair's paper, and moved on to the Chief Exec's report, so I'll hand back to you now.
Diolch. Can I just say on that item, I think that's a very, very good way forward. I think we will only deliver the outcome we're looking for with the community. I don't think it's for the community or by the side of it. I think it's with the community, and the more that we can involve the community of St David's and the surrounding area in not just the outcome, but the process of how we're going to discharge this, I think the better, Jill. And I think you've offered that reassurance in your view, which is great.
Thank you for the board's support on that as well, Chair.
Great. Okay. Very good. Sorry, did you?
No, I think I've covered all the items. I'm just happy to take questions. There are some matters in the recommendations after we've given opportunity for questions.
Okay.
Rodri.
Yeah, thank you. If we just look at the planned care allocation, and obviously you've got a plan, and we are very grateful for all money allocated for orthopaedics and ophthalmology. The 6.3 million, it is to support resolution of forecast breaches, but is that amount of money enough to cover kind of the breaches that we've got?
So, happy to.
Great. Let's Andrew come in, and then Chantal.
Yeah, Diolch, thanks for the question, Rodri. Yes, so the money's been allocated very much on the basis of what we estimated it would take to clear those breaches. We've probably got at the moment around a 50 to 100 patient risk in the orthopaedic number, just because when we did the assessment of what capacity we needed and the cost for the bid, that was a couple of months before we had the money allocated. So we've lost potentially with the independent sector a couple of months of delivery, because they probably won't be able to start until January. So we're just working through how we mitigate some of that risk, and that in part links into the Chief Executive's comment about possibly needing another Chair's action around some allocation of contracts to support mitigating that position further.
So we were given the whole allocation that we asked for?
We were, right, so we were given that allocation specifically in terms of RTT. We also asked for further funding to support our diagnostic position. That money was not all forthcoming in the allocation we've got. I should add as well, just by way of an update, I've had a phone call this morning with Welsh Government, who are quite keen to support us further in terms of outpatient waiting times, and have invited us, because of our track record of delivery on planned care, and Swansea for the same reason, to submit a bid or a response by Christmas about what more we might be able to do in the stage 1 waiting times position as well, to reduce the numbers on the waiting list. So we'll be working through that over the next few weeks as well.
Thanks.
Great, that's very good news. I suspect this is an issue of timing as opposed to resource, so it's managing to do this within the context of the financial year. And that's the critical element here, I think, Rodri, more so than the resource. Chantal.
Diolch, Chair. I'm trying my Welsh, but it's not very good, I have to say. And yes, I just wondered about, whether we've got the capacity to be able to deliver, against that funding. So even if we were to outsource to independent partners, will some of our staff probably work for the independent partners as well, and so would we have the capacity to be able to make good on that funding?
Before Andrew comes in, I would say there's a broader systems issue, which is everybody in Wales, all the health boards, are similarly trying to develop approaches and pathways to working with external contractors now at this current time. So there's a lot of pressure inside the system. I think the real challenge is for us not to allow that to become too competitive, to try and find a way to be collaborative inside that space. Andrew.
Yeah, no, I mean, I think that what you've said there is absolutely correct. I think the issue is purely around, in terms of the risk we've got on that number at the moment, it's purely around the fact that when we went out initially to see what capacity was available to us, both internally and externally, externally they were assuming, and internally we were assuming a couple of months further delivery based on when we thought we might, assumptions we made around when we might get funding allocated. I think there is a challenge for us in terms of our own workforce and perhaps enthusiasm or willingness to want to pick up those sessions internally for a whole host of reasons, which is why we're probably at this point relying more on the independent sector than we would like to, and certainly on the conversations we had as an executive team yesterday on the first cut of numbers for next year, demanding capacity analysis for next year, was could we find a way of taking a more strategic approach to planning capacity in this space over the next year or two based on what we know we're going to have to deliver and a proper full assessment of what the recovery cost would be, because I think we felt we could probably do something better value if we approached it slightly differently going forward. So there's just that's an early conversation at the moment.
Great. I think that's a very good idea, because what slightly worries me is we get to the end of March and we think we've solved the problem. And we haven't solved the problem. We've just managed to catch up on ourselves inside this space. We need a strategic mid to long-term solution around how we resource this that avoids the issue of us becoming a hostage to fortune to wider market forces in terms of resourcing. Hugh, did you want to add anything? Are you comfortable with that?
In agreement. I think there's a real challenge in terms of value for money from this. So we can, while we can secure the recovery, it becomes a real challenge to demonstrate value to the taxpayer. Doing it more proactively will give us that opportunity.
Very good. Last comment, and then I'm going to move us forward. Yes, please, Anne.
Thank you. I have a slight concern, because are the packages being dealt with the treatment and the therapies, or are the therapies coming back into our service to pick up from the private sector? Because that's happened in the past. It's gone both ways.
It just pushes up, it creates a pressure point further in the system.
Yeah.
We have generally tried to commission packages to mitigate that, but if you don't mind, I'll specifically check on where that sits with all of the, because we've got 2 or 3 different providers we're looking at in terms of orthopaedics, but where that will probably be the biggest issue. So I'll come back to you on that if that's okay, just so I know whether that's consistently how we've procured that, depending on what they've come back with.
Great. I think that's the value of impact assessment in a sense. We need to impact assess what might be the consequence of this work in terms of all the other allied kind of therapies and professions that sit around that. Great, thank you. Derek, last question, and I'm going to move us on.
Diolch, I wanted to squeeze it in. It's really about the GCC and the new committee being aware and cognizant of the needs and the challenges for our Mid and West Wales population, because I understand that there are going to be lay members, but as we're aware as a board, before, historically, membership was made out of the existing health boards, and I just want assurance that patients and families' needs and experiences will be considered by that new committee.
Diolch, Delyth. So I think on the way the joint committee, commissioning committee is constituted, all of the chief execs sit around the committee. So there's a strong voice from Hawddar, Powys and Betsy Cadwaladr. Hawddar's represented by myself. There is a geographical spread of independent members on the committee, and my experience with the emergency medical retrieval discussions that we've had has been that actually Mid Wales has been the focus of discussions. But I think it's right that we continuously test that.
As a further assurance, Delyth, I was involved in the recruitment of the IMs to it, and I was impressed with the breadth of the individuals who came forward, not just in terms of their connection with patient experience, but just their broad ethnic representation inside that space. It was very reassuring.
Just to add for Delith some assurance, there are two subcommittees under the Joint Commissioning Committee. One is on quality, safety and experience. So there is a separate underneath there where more detail will be done on the areas that you're looking at as well.
Great, okay. Shall I then move back to the Chair's report? It is as it's presented. I'm very happy to respond to any questions or inquiries you might have on the report itself. The only thing I would add is that you'll all be aware, as I am, that we've just completed our kind of late mid-year review of your performance and my performance as IMs, which I think will be helpful in terms of planning next year's programmes of activity for all of us. I think the other thing I would kind of most of the things that we see in Europe are linked to the agenda today. So the corporate services plan, the work that we've engaged in relation to that, is very much part of our conversation later on. The NHS Confederation event was a fantastic opportunity to network and meet with others across the NHS and to share that sense of experience and challenge that I think we're all experiencing at the current time. I chaired a kind of panel, a challenge board that was very much about thinking about that broad question about how do we create and sustain good health across Wales, which was very fruitful and prodigious and a rich conversation. I suspect we need to have more of those conversations because we make assumptions about what we think we're doing inside this space, but actually the more that we can have an informed and rich discussion about what we're all trying to do to improve health, the better. And I think we sometimes don't do it enough inside those kind of fora and environments that we're working as professionals inside this organisation. I'm happy to take any questions or any comments. The last thing I would say is since we last met, I visited Withybush, and frankly had a fantastic experience talking to staff at Withybush. I was deeply impressed with just the way in which they work as a system. So it was reassuring, and it was humbling, in fact, in terms of some of their work around frailty. Their recognition of the importance of flow through the hospital, their passion and their concern and their drive to want to find a solution that is systems wide, I thought was deeply impressive. I was really impressed with it. And in fact, I was so impressed, I've invited the Cabinet Secretary to attend Withybush as well, and to try to understand some of the work that's taking place there, which I think is unique. That is not for a moment to devalue or diminish the work of other hospitals within this health board, who I think are doing similarly fantastic work, and I hope to continue to visit them as we move forward to just capture some of that insight of the work that's taking place inside those environments. But it was truly impressive, truly impressive. Questions or comments? Yes, please.
Thank you, diolch Cadeirydd. Only just to add that to your point about the Withybush experience, I think whilst it's not solved, we still have challenging days in Withybush. Yesterday was a challenging day for performance. What I think I would agree with you when you go to visit the teams, there's a real energy and distributed leadership through a whole range of professions working together. And I think the other part of it, which I wanted to mention, was the system point. And I think the connection, the learning that I think we're seeing between our local authority teams and our own teams working together, using a similar methodology of improvement, I think is really impressive. And I say that knowing that we've got Michael Gray around the table, who I think has been a big instigator for that. So I wanted just to pay a bit of tribute to Michael's leadership in that.
I agree with that. I mean, I think it's not to suggest that the answers have been found, but often in my work, I look ahead to the point where I think we would be successful, and then look back to see what would have brought about that success over time. And you can see the green shoots of that success inside Withybush. So I think if we were to project ourselves into the future and look back to say, why were we successful? We would see some of those reasons to be in the behaviour of people working in Withybush at the current time. And it's that systems approach, your point, and everybody kind of understanding how they all make a difference inside that space. Great. Anna.
I'd like to just recognise the autism understanding status that's reported at the final section of your report today, and I think as our autism understanding increases, it should make us even more impatient for solutions for children, young people and families in terms of accessing the assessment and support that is needed, which has been a millstone around this board's neck, and not to mention for the families affected for years, and is a position across Wales which is completely unacceptable. And I think just today actually there's the second day of a rapid improvement event in Lampeter to try to look at what those all-Wales solutions might be. My specific question though is, having made some progress around our understanding in a patient-oriented sense, what work we are doing as an employer to ensure that our environments for work are accessible and autism friendly.
Great question. I'm going to turn to Lisa to respond to that.
Okay, diolch yn fawr. That's a very good question, and we are probably not doing enough. So some of the work that we are doing with our equality and diversity team and our learning and development team is how can we consider roles in a completely different way. So we're talking about job carving, we're talking about coaching support, we're talking about buddying systems. So it's all very much early thoughts at the moment and small steps of progress. We have got a particular training programme that is currently running at the moment with one of our local colleges around how we provide a different type of work experience as well and support individuals into the workplace. So I think there's more we need to do on that through our people committee.
Great. And if I just briefly come back on that, sensory environments are actually absolutely essential for neurodivergent people.
Yes.
So when we're thinking about capital investment, refurbs and so on, thinking about how a building is lit, what the noise is in that building, etc.,
Yes.
etc., is actually incredibly important for people who have those experiences. So it'd be great to get some connections going across the different parts of our organisation to really understand this agenda.
Yes, thank you. Can I just come back on one point as well? We've certainly flagged that as well with open plan working. So the environment that we move to more now is around that, and actually some individuals need their own space and their own surroundings, so it's how we are mindful of that and don't create tensions in our new plans.
Thank you.
Very good. Right, thank you, Anna. That's a really important point. Can I move us to our next item, which is just a kind of update on the work that we've been doing with Swansea Bay University Health Board. This is our joint initiative to bring together a committee that would allow us to think regionally about the way in which we deliver our services across South West and West Wales. You would have had the opportunity to see the paper. I'm going to ask Phil to suggest whether anything he would add to that. The thing I would say is that a paper similar to this, with all the detail of this paper, will also go to Swansea Bay University Health Board. So what we're trying to do is to ensure that we are moving forward together, and that at the first meeting in January we will be agreeing the terms of reference and start to scope out what we think is the programme of work we need to undertake in the future. The issue for me is the more that we develop our agenda within Howdda, the more I'm aware that we need to take a regional lens to how we think about the services we're provided. Because actually it's about our wider population. If we stop thinking organisation, we start thinking population, then the regional kind of approach to how we deliver services seems so much more critical and important. I suspect we're learning to do this because I think we've been trained to think very organisationally and in a bounded kind of way. But I think all the kind of early stages of this process suggest to me there's an enormous amount of commitment and passion for wanting to develop this, and I think we'll continue on this journey with some degree of enthusiasm and energy as we start 2025.
Diolch, Cadeirydd. So, yeah, I think the paper does demonstrate that commitment. We did have what I thought was a really productive board-to-board session in October that I know yourself and the Chair and Swansea Bay led. I thought that was something that probably we haven't quite had before. And I think the design principles in this paper do give a sense of how we're looking at this in a kind of systematic way. When you look at our clinical services, nearly every single clinical service that we run has some sort of regional component, and we've always been aware of this. And I think the joint committee approach, if we get it right, gives us a real opportunity to provide better value and outcomes for our population. We do have a meeting set in January, I think January the 15th, for our first meeting of the Joint Committee. We've got a draft terms of reference prepared, and we're also already in discussions corporately with Swansea Bay across a range of teams in how we best share our resources across the region, because I think when you look at us as a sort of 800,000 or 900,000 population, it's important to make sure we're not just duplicating for the sake of it, of just having two organisations. So I'm grateful for the executives who are engaged in those discussions with their counterparts in Swansea. Also grateful for Jo and her team, along with Hazel in Swansea Bay, for preparation of the documents and getting us ready for January the 15th. But I think this probably signals quite an exciting phase of transition for us as a health board, and I also agree with you, Chair, that there will be a lot of learning for us because we've been very used to working in a certain way, and also statutorily it kind of directs us into working that way. So I'm sure we'll find a way through all of that.
Great, okay. Thank you, Bill. Colleagues, any thoughts or questions? Chantal?
Diolch, Chair, because I can't say that other word, sorry. And I was just thinking about, in the meantime, and whether this includes, for example, a moratorium on delaying appointments in order to look at future appointments on a more regional basis as part and parcel of the joint committee. So rather than each organisation appointing individuals now, and then perhaps in the future might be relooking at those appointments, or whether there's been an agreement that we would delay any kind of appointments in order to look towards perhaps having appointments that reflects their role within the regions.
So appointments as in clinical appointments? Clinical appointments. Okay.
For the specific area that we're looking at.
Okay. I mean, before I come to Andrew, what I would say is the thing that, it didn't surprise me, but it reassured me when we had our joint meeting, was how much work is currently taking place across the two boards. It is sizable, the amount of service, co-service delivery, co-productive delivery that's taking place across the area at the current time. So I was reassured by that. So I suspect we're at one level, we are optimizing in many ways the kind of the clinical community inside that space. But there may be things that we need to think about in terms of future appointments that Andrew can help us understand more.
Diolch, Cadeirydd. We're looking at that anyway in terms of some of the regional services that we're already working through. So we've, for example, appointed joint leadership roles to mortuary services, and we're working through how we do that across the regional pathology network space in South West Wales as well. So that's a natural kind of next step. One of the things I was going to add, I think one of the really positive aspects of this and the way the conversation went is, and a reflection from the work we've done so far, is I think we've tended to approach regional work as a bit transactional. I think there's a real opportunity in this to frame this around particularly with the behaviours and the cultural piece, to get teams to think differently about how we work together and see it both in terms of service and leadership terms as less of a threatening environment and one whereby we can make a real difference. I think that'll be an important part of how we go forward, just from my own reflections of how pathology, orthopaedics and ophthalmology and things like that have been running. So I think that's a real positive aspect of the principles. But yeah, the joint appointments is definitely something operationally we're exploring in real time.
Great. Okay, thank you, Andrew.
Diolch, Cadeirydd. Yn cydnabod bod gweithio mewn partneriaeth yn her, to acknowledge that partnership working can be quite challenging, and I was really reassured at the joint meeting we had that people recognise that, but are committed to the trust and the evidence and the future-proofing of our services in those design principles to make this work. I think there are very pragmatic, practical things that Andrew has talked about, but also recognising Cyhoeddus has its 3 local authorities. Swansea Bay has its 3, I think, if not 2 into the 3rd. There is a genuine desire to make this work for the population of that area, and it needs the leadership that it's set up to provide, and that has to trickle down into the practicalities and the clinical services, and also the communication to our population that this is happening, not because we want to merge things, not because we want to do a great big change, but to take advantage and have the most effective, efficient service for the health of the population across the piece. And I think we have to keep that big picture in mind and communicate it really well.
Yeah, good, very good point. We do need to think about, because we are thinking of this as a systems level, but where it needs to impact is at a very local people community level. So I think you're right, Eleanor. Very good. Did you want to?
Just on the point about moratorium on appointments, we're taking, as Andrew said, some really deliberate steps where we see opportunities, and I think the joint committee will allow us to see more clearly some of those opportunities and explore them more deliberately. But we're not suggesting a moratorium, because actually there's a lot of business that we need to be getting on with. We can't afford to have gaps and wait. But actually, it's not just in very clinical services that we already have joint appointments. There's so I understand through talking to our Director of Public Health, we have a Healthy Weight. The person who leads our Healthy Weight is a programme is a region appointment, for example. So it's not. This is a completely new path for us.
Great. Okay. Thank you. In the interest of time, I'm going to move us on, but just to seek your approval to the design principles that we've agreed undertaking this joint work. Is everybody comfortable with them? Great. Okay. Let's agree that and note the update. Fine. Can I take us to our next item, which is delivering on our purpose, quality, safety and performance. And we're starting off by focusing upon the financial report. Hugh, I'm going to hand over to you.
Diolch, Cadeirydd. Yes, it's been a good month in terms of our position. If I remind the board that the required run rate for us for this year would have been a deficit of 5.3 million in order to achieve our forecast of 64 million. We're actually at 4.3 million in month, so that is a good position for us to have achieved. But in order to get to our target control total, we'd require a run rate of 3.7 million. So there's still quite some way to go before we get to that level. And the position in month, there were a number of one-off benefits that we benefited from, including settling on our contractual position with Bwrdd, which gave us a £400,000 catch-up for the year. So there were a few one-off elements that came into that position as well. But underlying that, there has been a continued improvement in our use of agency and a confluence of agency improving alongside overtime improving and bank improving. So that does pull together into an underlying improvement in our position. There has been an improvement in our underlying deficit this year. So as our outturn has only marginally improved based on last year's position, actually our underlying deficit has improved by around 20 million. So there has been a demonstrable stabilisation of our position this year, and that's going to be a challenge that we need to maintain in terms of delivery going into next year, and I'll come on to our plan for next year shortly. I think with the in-month position, we've got greater assurance of achieving our forecast of 64 million for this year. And that's positive, and I think that's a good place for us to be at this point in the year, recognising it's not good enough and we need to go further. But with that 64 million, I think there are a number of risks that we're managing, but I'm confident that we can manage those and achieve that 64 million position at this point in time. I just want to go back and recognise that the position for this year is the first year of a 2-year plan that we brought to the board back in March to get to our target control total at the end of next year. Now that's been a position that we've been consistently reporting upon, both to the board and to Welsh Government.
So just to clarify, March 26?
26, yes. And the last point I just want to make before opening up to discussion is there is a requirement for us to submit a request for strategic cash support. This is an annual request that, as we are in a deficit position, we need to request that additional funding from Welsh Government in cash terms. That request is included in the pack, and that is a formal letter that will need to be sent in from the accountable officer in the chief executive into Welsh Government to secure that position going into the year end. That is a standard process that we're following. And the letter, I hope, is clear, but there are three elements to the letter. And the first is the 64 million. The second is changes in our balance sheet that have a cash consequence, which is another 40 million, and then capital cash coverage that we also need to secure. So, Chair, with that, I think I'm happy opening up to discussion.
Okay, I'm happy to take questions or comments. Chantal, what it would be quite useful to do in terms of taking questions and comments is to focus on what we're being asked to approve as part of the board recommendations so that we can keep it nice and tight. Chantal.
Diolch, Chair. I was just wondering, it's just a quick query around the favourable variance as to whether that is sustainable over the months, when we're looking at it in the future. Will we be able to maintain that, or is this something that is unusual that has allowed for the favourable variance?
Thank you. There are... I mentioned the favourable position we're finding ourselves in terms of nurse agency. And that is a sustainable position now, and we are looking at further improvements that we would expect to see from that as further international nurses are recruited into position and are subsumed within the rosters. But there were some elements within the position in month that were one-off. Now, I'm not going to say no to any of those one-off gains, but I don't see that next month we'll be in a position where the deficit is 4.3 million. I think it will bounce back to a certain extent. I see it closer to 5 million next month, unless there are other benefits that happen to come along. So I think it's going to bounce back a little.
Great, okay, thank you. Michael. And then Dennis.
On your point, Chair, about looking at the what we're asked to do. So where it says that we seek assurance that those directories who are at level 3 escalation have got sufficient plans and milestones in place, how, Hugh, are we assured of that then, in a nutshell? How am I assured of that?
Chair, the number of directorates in level 3 is included within the IPAR report, so we've got the heat map in there. I think that is a broad question. There are more directorates who are escalated for finance than for any other domain. I think that's pretty clear, and I'll come on to that in the IPAR report. We do have an escalation process that is meeting with those directorates on a monthly basis, and that's subject to scrutiny from exec colleagues. And naturally, as the lead for that domain. I'm particularly interested in the reflections there. But at this point in time, I wouldn't say I have sufficient assurance to provide the board with around the performance of those directorates, and that's subject to ongoing challenge within the executive team.
Okay, so Delith and then Rodri, let's take both your questions before we, and then ask you to respond to both.
Diolch, Cadeirydd. It's really leading on from Michael's point, and maybe Hugh will want to cover it in the IPAR, about medical variable pay and whether we are going to be entering the winter period. And my other question, which I asked at last board, is again about drugs, about primary and secondary care prescribing. Now, that is a national issue, and I would expect there is a prediction that there will be an increase in costs over the winter period. So my ask is, what really is being done to mitigate both the variable pay on the medical side and drugs prescribing?
Okay, before you come back, Hugh, let's go to Rodri.
Yeah, I suppose it's quite similar, but I just want clarity. I don't want to divulge, but agency premium locums, we've dropped 1 million in month, yeah, which I think is brilliant. I just wanted to see what's the core reason. Is it more overseas nursing, or are we pointing to the premium locums, or are we just using a job vacancy to save that money? I just wanted to get that clarity, because it does make a difference to kind of a £1 million is a big gap, isn't it? Which is good, but I just wanted to get clarity on the 15.8 from the 16.9 last month.
Yes.
Yeah, thank you. I can cover both the agency and medical variable pay, and I'm sure I might bring in Lisa just to provide a bit more context and detail. But there is a degree of scrutiny that is undertaken through the financial control subgroup. We meet on a weekly basis, and we scrutinise all of our agency use within medical staffing. So that is a source of assurance that I can provide the board with. There is also an active programme now to roll out medical rostering across the health board, which provides us with less so assurance this year, but more going into next year will provide a really important element to our infrastructure to control that cost base going into the future. And of course, active recruitment activities ongoing as well. Before I ask Lisa to maybe comment, I'll just finish off with the drugs, and then we'll open it up. There clearly is an inflationary pressure that is driving our drugs spend, and within secondary care, it's mainly driven by oncology drugs, but there are other elements, rheumatology, gastroenterology as well. And what we're seeing there is two impacts really. Clearly a good news story in that people are living with cancer for longer, so there is clearly an additional burden on our drugs budget because of that. And we are seeing more activity coming through our SACT units, which is driving our cost and the inflationary pressure on top, as well as new and novel medications that are coming in that are making a demonstrable difference to outcomes, but of course come at a cost. Now, that's not to say that we just sit back and accept that cost burden. I think as opportunities arise to adopt biosimilars, which are better value, we are rapid in our process of adopting those, and as opportunities to use generic drugs come on board, we are rapid in our process of being able to get those into use. So it is an active process despite that growing trend of cost.
Great. Before I go to Lisa, I mean, several thoughts occur. I mean, the inflationary element of our drugs bill is not something we can control. Mm-hmm. But I think you've explained to us the fact that there are lots of things we can do inside that space to manage down what we think is the potential cost. And it feels to me we need to continue to work hard inside that space. My other question, Hugh, was with regard to medical rostering, because we know that we're carrying a non-recurrent financial burden into next year. Mm. And I wonder whether our advances in terms of medical rostering will offset some of that non-recurrent financial cost saving that we've managed to achieve this year but isn't predicted for next year?
I think it's tricky to make an assessment of that at this stage. What it does give us is the opportunity to have the infrastructure in place going into next year. So we'll have the tool set to be able to manage that better. We'll have better intelligence and we'll have a better understanding of it to be able to take more proactive actions going into next year. The challenge we've got currently is that our rosters are being managed by individuals on spreadsheets in a suboptimal way. Bringing that together, I think, will give us the evidence that we need to make changes in the future. I'm sure, Lisa, you've got some views on that as well.
Great, thank you. Lisa. And then Eleanor.
Okay, thank you. So in terms of nurse agency, our final cohort of overseas nurses is arriving any minute now. And that will bring a close to the programme. We are seeing a reduction in agency again in November. The one site that remains a higher use, but still less than we've had in previous months, is Bronglaus, who is receiving the final cohort. So we're really confident that the work that we are doing for nursing is stabilising the workforce. It's not just the overseas nursing, we are also seeing an increase in applicants from the UK, where people want to come and work within our organisation. So that programme is very much in control, and we're very confident of what we're seeing. Our medical one, we now have the task and finish group that's set up to mirror what we have done with our nursing workforce. And we have a team of people who are now working through a whole variety of things. So medical rostering is one. So our bank element of the rostering will go live on the 1st of January and the rostering will go live on the 1st of April. So we've got 2 pilot sites for the rostering. And once that begins, that will then give us all the intelligence that we need so that we can replicate and see how we can roll it out and whether we can also speed up a rollout. So that's been scoped with the company at the moment. We have had success in appointing locums. We have recently been in India as well, appointing medics, and have successfully appointed a number of doctors who will be joining us shortly. So it's a combination of a whole range of things that the team are working on, from rostering to agency reduction to replacing any high-cost agency workers. And we now have a robust process as well through the quality impact assessment tool to make sure any decisions that we make are not resulting in poor service and quality of care.
Thank you, Lisa. Eleanor.
Diolch, Cadeirydd. Two points, one specifically on some of the percentages and numbers in the paper, and one linked to the items that are coming next. A number of the areas have successfully hit their 5% going forward for this year to do the savings. A significant proportion haven't. What are our thoughts on how we increase the amount of savings that we make in the next year? Because our challenge is no less next year than it is this year. The second half of my question was, amongst all of this, clearly we have to communicate to the people that work in Howell the how and why we're doing this, because it's tough on the ground. They might have been out and about in a lot of the hospitals and a lot of our settings. What we see as great savings, they see as, why can't we have another band 4 to do this particular job? And I think it's unfair of us not to recognise the hardship quite loudly that causes. And on top of this, we have to have the bandwidth to make the savings in the right place, to shift towards greater care in our communities. And what I'd like some assurance of, for the purpose of the board, that we're strategising that for the future as well.
Good. Before you come back, Hugh, just to add to that, because I think that's really important. If I have an anxiety, it's kind of linked to the fact that I think large proportions of the organisation have made heroic cost savings this year, as you indicated, Hugh. Other parts haven't, and that might be because they lack the kind of financial maturity to be able to deliver against those savings, or just because it's difficult for them to do it. Inside with their service models, it's difficult for them to achieve those cost savings. My anxiety as we move forward is that we need to strategically build an approach to the way in which we kind of achieve further cost savings, so that so that actually we're just a bit more intelligent about the way in which we achieve that. So rather than think that to apply them across the board, think about how we target those cost savings, how they're built into our service planning, how they're built into our regional work, how they're built into everything else that we're managing to achieve inside this space. So it's not just that level of transaction. Now that might be there now. You might reassure me that that's what we're already doing, but that wouldn't be obvious.
Chair, thank you. So if I just pick off the issues in turn then, the percentage challenge is the first one to understand, and this probably adds to the risk we have going into next year, because there is a disconnect between those directorates that have delivered their 5% requirement and those that haven't, and that 5% was deliberately a step change requirement in savings. It's not going to be 5% forevermore. It had to be a step change to recognise the improvement in our deficit that we needed to achieve. Those areas that have been able to more readily achieve that have already achieved it. That increases the risk for the delivery of savings going into next year. And I think we need to be very cognizant of that going into next year. And that is a concern that I've got. In terms of allocating those savings in a more intelligent way, rather than just a blanket saving, because I am always worried about blanket savings approaches that effectively embed inefficiency in the way in which we operate. That is a real challenge for us. I acknowledge that. We have provided a degree of evidence back to the organisation on the opportunities that exist within those directorates. In fact, in some ways, the international nurse recruitment activity recognised over-reliance on agency, which drove a strategic programme in that space. We've got similar work on medical. We also recognise that we had a challenge in terms of our bed configuration. Those have been adopted within directorates in addressing their savings requirement for this year. But I recognise that allocating that blanket approach is not appropriate. It's particularly been drawn out this year, coming back to the question that Delith raised in terms of drugs budgets, because delivering significant savings against an ever-increasing drugs budget is clearly not something that we are going to be able to achieve. So we have to reflect on that going into the next planning cycle. But the default position will have to remain at this stage in terms of that blanket position, recognising we might need to flex that down for directorates that are finding that more challenging for good reason. If I reflect on the how and why question, that is always a challenge. Our duty to the taxpayer is something that doesn't always land well within an organisation that is providing services to patients that they've got in front of them and the population that they're here to serve. So that is always a tension. But that's a conversation that we are having through the whole team meetings that are chaired by the chief executive. So this is the whole of our team meeting that we have on a monthly basis. So that is a conversation that's held there, and clearly that is a message that is cascaded through us as leaders into our teams and is reinforced through our escalation meetings. So I think the messaging and the understanding of why we need to deliver this is clearly understood. Not necessarily consistently understood across the organisation, quite naturally, and there's always more work we need to be doing on the cultural development of our team. Bandwidth was a point that you also raised in terms of planning. I think one of my concerns is that we are delivering the savings that we can within our current operating model, but at some point the operating model itself needs to shift in order to deliver a change. Now, we are earlier in considering our planning this year than we've ever been in the past. So we've been having planning conversations for probably 6 weeks over that now. I'm sure Lee will know the exact time. But
I fully recognise that the question links into the other papers that follow as well.
Yeah, no, that's fine.
Yes.
So we are earlier in our thinking there, but recognising that the scale of change going into next year and the year after is going to be that much more significant, because the low-hanging fruit's already been plucked, we need to be earlier as well in order to get there. And lastly, Chair, before I finish, I'm conscious that Chantal asked a question at the start, which I haven't responded to, in terms of narrative, and narrative down to a directorate level. I'm happy to reflect on the level of detail in the report. It's always a balance between trying to keep it to a tight report that provides the level of assurance the board needs, but versus the depth that allows for further discussion. Happy to have that conversation, and naturally that's something we'll reflect on in SRC. We've got a report coming back from the FP&D NHS executive on our financial reporting that benchmarked us against best practice. That's coming back to SRC at the next meeting, and we can reflect on that in the mix of that conversation.
Great, okay. Thank you, very helpful, and I think you've covered off lots of issues that I think we were thinking about as an IM community in terms of how we shift ourselves into that strategic space. So, you know, we work to this principle of cutting our cloth, but actually we have to redesign what we're tailoring inside this space. We're not just making something smaller, we're making it different. And I think that is the transformation. It takes us from transaction to transformation, and that's where we have to get to. And on that maturity curve, in terms of cost savings, we're kind of only a third of a way along that process at the moment. We've got some way to go. But good progress, and thank you to everybody across the organisation who've managed to deliver those cost savings at the current time, because it is heroic in a history of not having done that before. Hugh, and then...
sorry. Just to build on the how and the why question, and Hugh's point, I think what we're very keen to do in the discussion with the organisation, and particularly the clinical operational teams, is take it from the lens of the patient pathway, the care and the outcomes that we're receiving, because all the areas that we're describing savings opportunities, they also manifest poor outcomes, poor quality, poor patient experience. So whether it's the nurse staffing work, the medical staffing work, the issues around delays accessing our hospitals and then being discharged back to people's homes, which is where people want to be. So it's we're not in contradiction then, I guess, in that balance between quality and financial savings. We're trying to work with the what people observe on a daily basis and where they want to see improvements with quality and patient experience.
Thank you very much, Lee. Michael, welcome.
Thank you, Chair. I was just looking for some clarity on one point of the report. It's page 3. It's the second bullet point under the forecast deficit. And it states that the board's expected to improve on the planned deficit, but at this stage, there's no assured plans in place that would deliver that. I just found that quite difficult to reconcile in my head, that you would expect something, but you didn't necessarily have a plan in place to deliver it. So I'm not sure if it's just the clarity of language in the report, but I'd appreciate a view on that.
The world of contradictions.
Yes.
Well, good point to raise. Hugh, do you want to pick up Michael's point?
Yes, I hope the finance report isn't too contradictory, but we will. I'll endeavour to respond. I think there is we have an assured trajectory to get to our 64 million, but we don't have an assured trajectory to get to our target control total of 44.8 million. That's what Welsh Government set as their requirement, but we have been consistent in what we've said, in that we wouldn't be able to achieve all of that in 1 year. We had to take this step by step in terms of the scale of change that the organisation could absorb in any 1 year. So the first stage of that, I think we've got to, in terms of getting to a assured position against our 64 million. The second stage of that, there's more work to do, and that's part of next year's planning round.
So, very helpful. The thing I would say as a board, we need to be assured that the approach we're taking is the right approach. So the things that you've just said, Lee, in terms of ensuring there's a balance and there's a journey towards delivering those ultimate cost savings, we need to be assured that that's the best and right thing for us to do at the current time and into the future. And I think it would be really helpful at our next board meeting to look at our approach. So to think about that strategic approach as we kind of lean into the future, what we're going to deliver in there. Because if I have an anxiety, it's around clinical safety and effectiveness. What we can't do is compromise. There are things we cannot compromise in this journey that we're going to have to navigate with and through as part of that process. So as a board, we need assurance that we are still maintaining all at that level that we would want to, at the same time as delivering the cost savings into the future in a realistic but challenging way. Would you be comfortable with that?
Absolutely. Achieving a financial position is quite easy if there is no consideration of the quality that we're providing. I think the way in which we approach this has been to think about value first, rather than just cutting costs without consideration of value. And our savings do have quality impact assessments and equality impact assessments against them to provide that assurance that we're not doing this to the detriment of our patients and population.
Great. So let's bring a paper to the board in January, which will broadly focus on our approach to those cost savings, so we can be assured that it's robust and it's giving us what we need. Great. In terms of our accountability, Anna.
Thanks, Chair, and it builds on Michael's question, really. Given that Welsh Government has been unambiguous in its messaging to us that 64 million outturn, forecast outturn is unacceptable, how do we rate our chances of a positive response to the strategic cash request for that 64 million?
At this point in time, the letter hasn't gone in, so I think I'd rather wait until the response comes through. But in terms of the position, I've been clear on the position throughout the year with Welsh Government, and my conversations with Welsh Government have been positive in recognising the consistency of our forecasting, and I've not had any indication that there would be a challenge in supporting that work. There is a challenge in supporting it. I've not had any indication that it won't be supported.
Thank you. So I just quickly want to run through the kind of recommendations, what we're asked to do as a board. So clearly recognising the challenging position we're finding ourselves in, and recognising that it's not acceptable at the current time that we haven't reached the 44.8 target, and that we are looking to reach 64 million by the end of this financial year. So let's just be clear about that. We're living with a sense that this is unacceptable at the current time, which is frankly painful and a bit uncomfortable as a board, but it's something that we recognise we need to do. We've largely, hopefully, scrutinised the where we think those savings are taking place, and I think some of the conversations about the disparity between some and others is evidence of that. We do acknowledge the work that people have put into this, Hugh. I think that's really important, and we are thankful to those departments and divisions within the organisations that have demonstrated the fact that they've delivered cost savings in this area and still managed to deliver their services. And I suspect we will ask more of the organisation in the future year, but we are grateful and thankful for the work they've undertaken. In terms of, we've also scrutinised the issue around where there is overspend or where people are not meeting their targets, and you've assured us that there is clear kind of recovery and scrutiny around the work of those parts of the organisation. In terms of more broadly, am I happy to? Are we happy to agree the fact that we are approve the strategic cash request of 64 million?
Yes.
People don't look very happy. I'm looking at Anna. She doesn't look very happy.
I can't see that we've got a choice, but I still think that position is unsatisfactory.
Fine. Well, we accept that as well as part of the process, but it's kind of with a heavy heart we arrive ourselves at this position, isn't it? Yeah. We're not gleeful about this at all. So, but clearly we will need to petition Welsh Government to cover those costs, and also in the event that that's not forthcoming, then we will need to operate our cash management strategy, which will be pretty radical if we find ourselves in that position, and just to recognise as a board that that's an approach we will need to take if we can't secure the additional resources we need from Welsh Government. Everybody I'm looking for endorsement. I'm not looking for comfort or happiness or pleasure or any of the other associated positive emotions we usually experience when we're agreeing some of this stuff.
Endorsed.
Great, okay, thank you for that. I'm conscious we're running a little bit late, but I do want to move us on before we take a break. Can I move us to the annual plan, which I think, Lee, you're going to take us through now, and which I think connects the paper we've just discussed. Please.
It does, David. Yes, it does. So we've stepped into some of the conversation already. So the paper obviously provides an update on both the delivery of this year's plan, particularly within the context of target intervention and the development to date on the 25-26 plan. We also, of course, have a further item later on the broader strategy, which begins to overlap into some of these questions. So we'll pick up those wider conversations in that item. I think the paper itself is quite self-explanatory, but I'll just highlight a few key points. Firstly, we have received confirmation from Welsh Government that our escalation status remains unchanged following a recent review, so we remain in targeted intervention. With regard to the delivery of this year's plan, we've of course got the IPAR later, and we've just had the finance paper, but this paper highlights some key areas where we are on track or ahead of our plan, and a few key areas to alert the board in relation to the target intervention criteria, which we may want to have a discussion on probably in the IPAR item, I would suggest. Given our distance, as we start to think about our plan for next year, given our distance from the financial balance, as we've just discussed, our assumption at this point is that we will not be in a position to produce an integrated medium-term plan because we won't be able to get to a financially balanced position. As we've just stated, that of course is an unacceptable position. It is a breach of our statutory duty as an organisation and is a very serious position for us to find ourselves in. But at this point, we see it unlikely that we can come to a different outcome to that in our planning over the remaining months. The work to develop the plan is well underway. As noted earlier, we have been working at it for the last couple of months. We've had 2 workshops. We've been discussing in the last round of Directorate Improving Together sessions where each directorate is with their plans for next year. And we've also been running some dedicated strategic conversations in our business executive meetings in alternate weeks as well. So the first draft of plans for directorates are expected tomorrow, and we will be collating that through the course of next week, and then considering what further we need to do through December and January to be in a position to bring the plan to board at the end of March. So I'll take any questions there, Chair. Thank you.
Great, thank you, Lee. Just for clarification in my head, it's about the logic of not being able to complete an integrated medium-term plan, because it feels to me, if the medium plan is 3 years and we are projecting or aspiring to balance in the middle year, then we will, over the course of the IMTP, balance our books.
Well, so we'd have to balance over the 3 years combined, but perhaps I'll he wants to come in, so I can
mathematically, Chair, in order to achieve that, we need to generate a surplus then in year 3 that would offset any overspend that would be incurring in year 1 of the plan. So clearly, achieving that would be very, very challenging for us.
Okay, thank you. Helpful. Colleagues, questions? Winston, Chantal? So let's go to Winston and then Chantal.
Yeah, firstly, thanks for setting out the approach in terms of the plan itself. I just want to draw attention to the, when we're talking about key deliverables for 25-26, we talk about substantial improvement to the financial trajectory, but we're asking ourselves only to make a 1.5% savings. So should we be a little bit more ambitious in relation to that figure? Well, first part of that. Second part of it is that ambition ought to be driven by accepting that we need to invest in some of the other areas. Because when I look at what we're asking ourselves to do, continued improvement in planned care, cancer diagnostics, stabilisation of medical workforce, a development of primary and community strategic plan, presumably that would require some investment. So in my mind, in order to fund that investment, don't we need to make challenges on more savings? That's the challenge I'm sort of setting to execs. Because on the one hand, if we made more ambitious savings plans, equally, we would need to put some of those savings back into those areas which are fragile.
Well, we will come to that question. So Hugh, hold that whilst we go to Chantal. But just to say, I think that takes us back to our approach.
Yeah.
Fundamentally, what is our approach to cost saving in, over the course of the next 2 years? And I think that would be embedded in it. Thank you, Winston. Chantal.
I think it's on similar lines, but probably in a kind of a different way of expressing myself on this, is the fact that there's a percentage of things that we've not been able to achieve in terms of the 5%. And then next year we would be expecting them to make good on those things that they didn't achieve last year, plus the 1.5%. But how confident is the organisation in order to be able to achieve that?
Good point. Any other questions before I ask Hugh or Lee to comment on those issues? Fine. Before you press ahead, a positive comment, I would say, in terms of what plans need to demonstrate. I think that's a very robust list of criteria that they need to be delivering against. So well done. I think that hopefully that will result or impact in terms of quite mature plans in terms of people's activity and expenditure profile over the next 12 months. Hugh.
Chair, thank you. We're at a stage in terms of our planning financially where we don't know what the allocation for us for next year looks like. While the allocation into health at a UK government level has been very favourable, that is clearly an allocation for which there will be consequentials coming into Welsh Government, but Welsh Government may decide to spend that on anything within their domain. And in fact, there was a step change investment this year from Welsh Government into health that is only now being reflected and made good at a UK level into health in England. So we are in a way ahead in terms of the allocation that came into health, and Welsh Government may choose to spend on other areas of priority. So what you have in front of you is very much just a staging post and an expectation of what we should be able to achieve before we receive that certainty over allocation. So in our, as an executive team, we agreed that we would plan for identifying £20 million worth of savings by Christmas, and we will reflect at that point on after the allocation on whether that is an ambitious enough position or whether we need to go further. So they are just staging posts at this point in time. As Lee said, the plans are due to be returned by Friday. We'll be able to assess then over December whether we're close to that £20 million challenge and requirement. The 1.5% position, I agreed with, in framing a 2-year plan last year, we recognised that there was a step change requirement, hence the 5%, and that we would then revert to and that combination of 5% and the new 1.5% would get us broadly to a 44.8% position. It would be slightly better than that. The 1.5%, which we will always have to deliver, was hooked onto a report which the Health Foundation wrote for Welsh Government pre-COVID on what an underlying level of financial savings should be achievable by the NHS in each and every year. Now, I recognise that's post-COVID, and Treasury, during the budget conversations, have come out with a 2% expectations for public sector organisations. So it may well be that we now need to revise that and reflect that. I want to wait until Christmas till we find out where we are against that target allocation, and then we'll refine that going into next year, Chair.
Great, okay. Winston's point, which I think is really important, is that we need headroom in our cost-saving strategy to ensure that we can invest in those areas of this organisation that, as a consequence of investment, will deliver long-term cost savings or productivity benefits that wouldn't have happened otherwise. So we've got to give ourselves some space to to grow the organisation through investment at the same time as looking to reduce our cost base.
Chair, if I may, there is a challenge here, which I'm sure we'll come back to when we come to approve the budget for next year, because we will still be an organisation in deficit. So anything we choose to spend will be a choice not to reduce that deficit further. So there is a conundrum for us to overcome at that point, because there is always that option to, if we create a transformation fund of a few £1 million, there's always the option to reduce our deficit by a few £1 million instead. So that is something we need to reflect on and debate as a board, and we'll come to that in Q4.
Great. I mean, so
come back a bit.
yes, please, Winston.
Yeah. So what I'm thinking of is, so the DARS report talks about moving the dial from delivering healthcare to prevention and from secondary to primary, and I'm thinking that won't just happen unless we do something about it. And one of the areas we could do is to say, well, actually, we'll set some ambitious savings plans, but equally we'll use some of that resource and put into those preventative measures and towards shifting the care. So that's what I'm thinking, actually. That yes, we will still be in deficit, but if we're in deficit and we've got forward plans to address it by shifting that dial, and I think we're in a better place than just being in deficit.
Yes.
Without that happening, and I guess that's my challenge at this stage, or in terms of our approach, and whether we could do that. I'm also minded that we've got fragile services as well, which we're bound to have to do something about those fragile services, because then we'd have immediate quality and safety risks. So we'd just end up spending anyway. So rather than doing that, I'd rather we did it in a planned way rather than it just happening to us as a health board.
Yeah.
Chair, I agree. I think there's a discipline of business cases that we need to reflect on. Is the dynamic here is, yes, we do need to shift our resources into those areas that Winston alluded to, but there is a time within which that payback will be realised. So there will be a net upfront investment and a payback over time. We need a robust business case for any decision that we take to do that. So rather than a blanket allocation, we need to do it with a degree of kind of guardrails around that to make sure we can be assured over the response we'll get.
Of course. I mean, I think the two of you are identifying for me how complex the future management of our financial position will be. We do need to invest. We do need to find ways in which we can improve our services, increase our productivity, reduce our cost base. That can only happen if we recognise the fact that actually any monies that we would have ordinarily might have used to reduce our overall deficit are being used to improve the future operation of the organisation. Now, even in those circumstances, it is possible for us to demonstrate a discipline around and a benefit around how we spend that money and what we think the benefits of it will yield. But you're right, Hugh, time is the critical issue here. It's about when we can deliver a payback in that situation. But I would like to think as an organisation that we have to find ways during this very challenging financial period that we continue to grow and evolve and improve our service portfolio and improve our productivity and reduce our cost base at the same time. That's why I'm quite keen to see our strategic approach to this in the new year. Adriana.
Thank you, Chair Diol. Thank you for the question and for the comment. Yes, not just DARSI, recently our own NHS Health Services Framework and does talk and really requests us to be taking a population health approach and to be increasing our efforts as well as our resources in prevention. I would just add that as a health board, we do have more opportunity to increase what in each of the main disease areas, if you like, rather than just services, we do to improve prevention, to improve our efforts in preventing the exacerbation of some of the conditions as well as really occurring in first place. Without necessarily having to develop the business cases. But if we look at the value element, and that's what we're working already with our clinical teams, trying to bring into their forethought of what in every day that when they meet their patients, what they can emphasize, what support they can provide. And we as a board will have our seminar in 2 weeks' time, and we'll be talking as a board a little bit more about what can we do. But we can't achieve that reduction of the demand that comes into without investing that upstream. And also the primary care and community strategy now that is being developed is absolutely a key tool for us to try and reduce the demand in our healthcare. Thank you.
Thank you, Adriana. A point well made, which is that some of the changes we want to introduce aren't just about money; they're about what people do every day and how they engage with patients and with wider communities. So, well made. A point well made. I'm not going to prolong this conversation. Did you have anything? You look as if you're anticipating something. Fine. Okay. Okay. Fine. I am going to ask Phil to comment before we close the item.
Okay, conscious we're coming up to the break. I think we are earlier than we've ever been at the stage of our planning process for the future year, and I think we're even considering it before we're clear on our allocation. So I think that's a really positive thing. It does mean, therefore, that the meetings that Lee's describing there, where we're meeting with directorates to consider information, means that we've got more time to consider that information more carefully. We've got more time to gather evidence, more time to triangulate, but also to consider our tactical approach. So I think that is all helpful. I was thinking that the point about the innovation fund, or trying to create some headspace, or however we describe it, is something that I've asked you to consider for the reasons that others have described. And I think it is difficult when you're in deficit to create that sort of be talking about investment, having an investment fund. But if we consider it over a 3 to 5 year period, consider our plans that it's not just a year and then it stops, and then plan another year. Some of the green shoots that we'll want to kind of propagate will, I think we'll see the benefits of those in future years. So I do think we need to have we don't want to consider our annual plan just within that short time frame. And the last thing is just we need to remind ourselves that our underlying deficit at the start of this year was 96.4 million. So getting to 64 million was a challenge that a number of us were quite concerned about at the start of the year. And I know we did discuss a number of times how we might get back to 44.8 million, and we were struggling to find a route. I mean, mathematically, I think we could describe it. We were struggling to find a route that wouldn't be incredibly detrimental to our population and our staff. Our underlying deficit will not be 64 million at the end of this year. It's going to be somewhere in the 70s. So to get back to 44.8 million next year is going to be a similar large task for this organisation, and that's on the back of us having tried to take out obviously the more amenable savings this year. So we shouldn't be under any illusion. It's not a small jump to 44.8. It's going to be a big task for all of us and all of our organisation, but one that we're up for. I suppose the point about getting them back to the kind of the balance, I think then is another step. So I think that's the challenge with us thinking about just credibly presenting an IMTP to government, to this board. But I would come back to the fact that even if we don't present an IMTP, we should present an annual plan within a 3-year context.
Yeah, absolutely. Absolutely.
Or if not longer.
Great. Thank you very much. So can we take assurance as a board from the actions that have been undertaken so far to reach an annual plan? It's Rodri.
Yeah, just on that point, from what you said before, so in the next board meeting, are we also expecting an approach paper on the way forward, because that's what you did discuss to start with. I'm fairly confident that should be a paper that we look at next time.
I think that would be very helpful, because all the things we've discussed, the potential for an investment fund, the way in which we want to be a bit more sophisticated in our approach to saving in the future, how we can link our one-year plan into our medium-term plan, even if it's not something that Welsh Government would want to entertain. All those things are really important. We cannot plan the future of this organisation on the basis of a single year. We cannot. You know, it is a recipe for not getting to an outcome that we all want to achieve. So we have to work towards that and recognise that's our role as an organisation. But well done to the work that's been undertaken inside this space. It's an endorsing thing to see that we've got to this stage so far, and there's a maturity taking place inside the organisation which increases our confidence as a board. Well done. Okay, we will due to break for refreshment, but I'm going to suggest there's a natural kind of connection to the next item, which is the kind of integrated performance report. So if I could just ask for your indulgence, I'm going to suggest we cover this item and then we'll take a refreshment break.
Diolch, Cadeirydd. I'll keep my introduction relatively brief. You've heard enough from me probably today. I think by now the alert, advise, assure method of reporting is well embedded in the way in which we report, but there are far too many areas in this report where they are here because of an alert to the board. I want to give the board assurance that they are under active management, and there is a process in place to work through the challenges underpinning each and every one of those areas. The escalation summary I've also included here as a heat map on page 8, and that demonstrates the changes in escalation we've had from September to October, and I hope demonstrates that management and the active management we have in addressing the challenges there. I think it's fair to say that increasingly now finance and performance domains are isolated as those areas that are now more concerning than perhaps the other areas generally across our directorates. But I do want to highlight concerns around mental health and LD, which is the directorate which remains at a very significant escalated level across every domain, and that we have included this and the management actions specifically that are being taken within that directorate. We don't have the notes of all of the escalation meetings. We've kept it just to mental health, given the assurance, given the concern around that. But there are similar kind of action plans in place for every directorate. Chair, with that, I'm happy to open up to discussion.
Great, thank you. Andrew, do you want to come in?
There are probably a couple of things I'd like to pick up, because I'm sure they'll be of concern, and they're concern to me, so I thought it'd be useful to provide a bit of an update. So obviously one of the first items there in the alert section is around cancer performance, which I'm obviously will share what I'm sure is a concern of the board around our drop in September to 40%. That's been driven by a couple of factors. One is in relation to a challenge in radiography reporting capacity that we experienced over the summer that impacted on the pathway and has played through as far as September. We have addressed that now, and our radiology reporting delays are the lowest they've been in the last 12 months, so confident that we've mitigated that issue going forward. The other key aspect was we made due to sickness over the course of the summer in our skin team pathway, there was an increase in delays in accessing skin cancer treatment. We've had a really focused approach through September and October in addressing the backlog in that area through increased capacity, and we saw our biggest reduction in the backlog figure in September for some time, which by virtue of reducing the backlog had a negative impact on our performance as well. We've taken action within the skin service to increase our capacity from 30 patients to 50 patients a week, which will make a big difference as we continue to go through the year. On the back of the actions we've taken, and there are other opportunities that we continue to explore, including continuing to see increase our straight to test rates, which are improving, but also any other opportunities to improve pathways. So urology is the next big one that we're really going to put some focus onto beyond what we have already. But I'm confident with the actions that we've taken, we will start to see an improvement in our performance for October. I think it will still be below 50%, so I would advise the board that it will still not be where we want it to be. I am hopeful, though, in November, based on where we are as of this week, we will see an improvement in November that gets us a much improved performance position. We have a revised trajectory in place now to the end of the year. When I tested that with the service, when we as execs tested it with the service yesterday, and asked whether the trajectory was now a reasonable worst case or a reasonable best case, the response was it was somewhere in the middle. So I'm taking that to mean that's the most likely case that we're going to see, but that would see us achieve the de-escalation criteria for the last 3 months of the year from a target intervention perspective, which would see performance over 60%. Well, of course, that wouldn't then, what it doesn't necessarily do is achieve our planned trajectory, which was to be achieving the single cancer pathway target of 75% by the end of the year. So there'll be a bit of variation from our plan, but there's it was just to try and provide some assurance to the board that there's obviously a lot of focus on cancer. We're working through how we continue to prioritise our capacity to improve performance in this area, because we recognise it's a really important area in terms of outcomes and patient concern, and for us as a board. So I did want to just make sure I covered that off before I took any questions.
Diolch, Andrew. I'm going to come to Eleanor.
Diolch, Cadeirydd. The one I want to pick out of this is the child neurodevelopmental weight. I recognise that there is improvement, and I also recognise the context of working on an all-Wales level to deal with what is a Wales-wide problem. Nevertheless, I've spent some time with our teams who are working in this area recently. They are absolutely swamped with the demand that is there. I want to acknowledge their efforts. They are doing the best that they can on a day-to-day basis in very difficult circumstances, with enormous care for the people that they're trying to look after. I'm really worried about this. And I'm worried because behind every statistic is a child. And waiting for an assessment for months and months or years as a child, it doesn't sit ethically very well with me that we cannot drive the improvement quicker in this space. It's more of a statement than a question. I suppose the question is, and what are we doing?
Yeah.
Yes.
Thank you, Eleanor.
Thank you.
Andrew.
Yes, I think just to just to comment, I totally recognise the concern, and I share that concern and that anxiety that causes us and causes our members of the public and children that are waiting to access that service. I think, as I've reported before, there's the conversation with Welsh Government has been that the target we've got is not deliverable or achievable within the current system. So that's always something that's in my mind. However, what we do have to do is make sure we're providing, because at the moment the target measures time to assessment. It doesn't really pick up the fact that we've got to, in a number of cases, then provide a treatment or an intervention thereafter. So within our service model, we're obviously trying to make sure that as well as improving assessments, we're also dealing then with the interventional treatment that individuals may need following their assessment. We've had an additional allocation from Welsh Government of £312,000 to spend before the end of March. That'll increase our capacity by around 190 assessments. It still is only a small, a very small chip away at the block in terms of the capacity we need, but we, the Director of Finance and myself have also had a conversation with the Directorate around opportunities within their financial position to the end of the year to source additional capacity over and above that which Welsh Government have funded. And we've also got a couple of discussions set up with potential alternative providers or service models that we're going to explore as part of that work. There is the accelerated design programme going on nationally in Lampeter yesterday and today. And certainly there's been a local regional workshop that I think Ardiana, the Director of Public Health, referred to earlier on. I think then one area where we probably need to strengthen from a service perspective is how we get a better conversation from an RPB perspective in terms of the regional response to neurodevelopmental services, and that's certainly something probably with Michael's support as our local authority rep, I'll look for us to pick up through our integrated executive group as well in terms of a conversation, because there is a statutory requirement for all of the organisations in the West Wales Partnership to participate in that service response. So there is a lot going on. I think where I'd like to get to is to be able to come here and say we're much closer to bridging the capacity gap than I'm able to at the moment. But it's certainly a work in progress, and we're trying to. Hopefully through that you can see we are taking every opportunity to increase capacity and find alternative solutions.
And I recognise the complexity of the funding sources that goes to that, which adds to the frustration of some of the people working in it. I'll be happier once I know we're doing as much as we can, as quickly as we can, because this doesn't just feel strategic. There's a real time issue for those involved in that.
I mean, one of the challenges, as I was reading this paper, I'll come to Rodri now, but one of the challenges I personally felt as I was reading this paper, because there are areas where we are clearly not performing to a standard that patients and the public can expect of us. There's also other areas where we are performing well, and I think those get kind of slightly shadowed by the stuff where we are suboptimal. The question in my head, or the questions in my head, are largely about what is within our control here and what is out of our control. So what is it we can do and what is it we can't, because it's not within our gift to do that. And also, what is about personal performance and what is about systems performance. And for me, those are critical when we come to think about how we improve our delivery of the kind of services we're engaged in. What is within our control? What is out of our control? What is critically focused on personal performance or systems performance, the way in which we manage it as a whole? Because I think until we understand some of those things, it's very difficult for us to navigate a pathway that improves the way in which we're delivering some of these services. I'm not expecting you to respond to that. But,
I'll have a go, but I'm
that's fine. I'm going to leave that with you.
Yeah.
Fine. Rodri, please.
Yeah, thank you. As you say, we are performing well in many spaces, but I just want to draw your attention to the escalation criteria, Appendix A, which is that final page. And I just want to, I know I ask this on a regular basis, but if we look at perhaps Director of Workforce and OD, and we look at the level 3 regarding issues, bullying and harassment, but also the sickness, there are issues in those areas, and if you look at the paper, the sickness is going up again. There is a deep dive into the sickness, I don't know where we are at regarding the deep dive into sickness, but those are very worrying trends, and for performance to improve, we need to improve on those as well. And level 3, no assurance at all. I just wanted to get some kind of an idea where we're at and how soon can we perhaps de-escalate this position.
Very good. Before, Adriana, did you have a question or a comment you want to make before I go to Lisa?
It was a comment in relation to the neurodevelopmental needs for children.
Okay, do you want to make that comment now? And then
I'll be brief, but I just wanted to add really to your point about where we have a responsibility, where we have something that is under our control and where we can influence. I'll just add that we are a statutory body of our public service boards, and we are also a member of the regional partnership board, and that is where it is also not just within our influence, and that's where we are trying to work, as Michael is here. The additional point, very well made, Eleanor, is that the children, the families, the communities are waiting for a very long time for an assessment. But then they're waiting also for the further management. And there is something that we need to do, with which is a point which I have highlighted in my Director of Public Health report, which we'll take on later, that we need to do with our communities to increase the resilience, to increase the wraparound support, and to reduce as appropriate as possible the over-medicalisation of some of the issues that can be well managed otherwise.
Thank you.
Well made. Thank you. Lisa, can I come back to you to respond to Rodri's comment? I think it's a really important issue, Rodri. It's come up on several times in terms of our performance around sickness absence.
Okay, thank you. So we have diverted some resource within the workforce and OD team to focus on sickness absence. So previously we had 2 individuals within the team that were dedicated to undertaking audits and supporting managers in terms of the process around the management of sickness. So an individual has been moved back into that role. They have now started to engage with some of our services. So there are some areas, hotel facilities is one that I would comment on, where we have seen a significant reduction in absence management, an increase in absence management, reduction in sickness absence. So the November figures at the moment are showing a decrease in sickness compared to October. It is early still, so the systems still do need to sync, but we are seeing something there. We also have a workshop in January now with our Occupational Health and Staff Psychological Wellbeing Service around how do we need to look at the service that we provide there to cater for our staff needs. So looking at our sickness rates, looking for the reasons for absence, also linking in with our Diana's team as well about what's happening with our population, because all of the epidemiology for our population is also for our staff. And we are looking to pilot a piece of work jointly to support our staff to identify their well-being and see whether we can adapt tools. So that's ongoing. And we are also working with our partnership forum as well around staff who are off on long-term sickness, who are able to work but not in their current role because of their type of illness, how we can work on a programme to bring them back into work in an alternative role whilst they either wait a procedure or recover from their illness to be able to return to their substantive post. So it's all actions that are taking place that won't see an immediate impact, but we are starting to track it through our different areas, and we have our Partnership Forum workshop next Tuesday where we'll be looking at progress of the Task and Finish group that's focusing on that return to work.
Okay.
Thank you very much. Hugh, did you want to say anything?
Chair, I just wanted to reflect on the system of escalation we have in place, and it speaks to the issue that you raised around system performance versus individual performance. I think that's really important. This is about a system performance assessment. The individual performance of our staff is a line management issue. The system we've put in place is very much about testing the collective impact that we're having. I just want to be clear about that this isn't indicative of individual performance issues.
No, I completely agree with that. It is a systems issue, but in my head, there's a golden thread.
Absolutely, of course.
Which runs down to what people are doing every day, whether they're in work or whether they're unwell, and how they tackle their role and how they perform. So there is a connection there, but I appreciate you're right. This isn't articulated in this paper, but it just lights a fire in my head about those issues and receiving the assurance. And I know we have received assurance that there's a high degree of performance management and completed appraisals within the organisation, and that number is going up more and more and more, which is indicative of the fact that there is that system in place, but we need that assurance as well as a board. Great, okay. We're asked to assure ourselves of the mitigations that are in place to address where we're not performing well at the moment, and I appreciate Andrew's given us some detail of that, which has been helpful. I'm going to presume from that we are relatively assured at the current time, but would wish to see improvement continue to be made across a number of areas where we are underperforming and frankly letting down the public and our patients at the current time. Great. On that basis, can I suggest we take a 10-minute break for some refreshments and then we'll reconvene at 20 to 12. Thank you, colleagues, for coming back so promptly so that we can continue to the next stage of the meeting. I'd like to take this to item, I think it's 3.5, which is Board Assurance Framework, and I'm going to ask Joe to lead on this item.
Diolch, Chair. So, as members will know, since the board in July, we've been working on the BAP in the background. All the committees have received a progress report on delivery against our planning objectives, which do underpin our strategic objectives. And just to remind members, the 10 planning objectives that we've got are those that we agreed when we agreed the annual plan at the beginning of the year, Chair, and the link to our planning framework and our ministerial priorities. So I wasn't going to go through the paper in detail because I know there may be some questions on some of the areas. And just to flag, there are 2 strategic objectives which we know haven't got planning objectives on. So when we start to do the strategy refresh work through the board seminar work in December, we will need to pick that up as well as part of that, Chair. So I'm happy to take any questions.
Thank you, Joe. Colleagues, thoughts or questions? Yes, please, Phil, and then Maynard.
Just one point on the last comment you made that Joe made there. We have over the last few years rationalised how many planning objectives we have. We had a large number last year and an even larger number the year before. That means that some of the pieces of work that were previously designated as planning objectives are still ongoing. They're just not called planning objectives. So it doesn't mean that there's no work being undertaken on those other strategic objectives. I think some of the examples will be around our recruitment campaigns or our work around value-based healthcare, where we're striving for excellence. So I think, you know, wouldn't want the public or board members to feel that there's just no work going on those areas and no progress being made. But I think we are in a period of transition, and I think when we get to our strategy paper, I think that re-looking and refreshing our strategy will also mean that we will need to also consider our strategic objectives as part of that process.
Thank you, Phil. That's reassuring. Maynard.
I've got a question on one of the specific comments in here. On page 6 of 10 at the bottom, it mentions that 84.9% of children are up to date with schedule vaccinations by age 5 for 4-in-1 preschool booster.
Maynard, pull the microphone to you a little bit.
My apologies. 84.9% of children are up to date with scheduled vaccinations by age 5, 4-in-1 preschool booster. I was just wondering what the general position with vaccination is, particularly this time of year. And we've had the strategy presented to SDOD. Just wondering what progress has been made against that generally.
Great, okay. Adriana, do you want to come back?
Diolch, Maynard, thank you. So, very good point that our uptake amongst the children for the primary immunisation is not as high as it needs to be, and certainly not as high as we would want it to be. However, there have been improvements in most. We have had some increase in uptake in some of the areas, which is the seasonal immunisation, which you're referring to. It is proving to be a difficult season for uptake amongst all eligible groups, and not just for our health board, Wales-wide, nationally, and wider. The efforts and the action plan that was developed on the back of the strategy to increase uptake and reduce equity in uptake for immunisation is underway. We're progressing with engagement mostly with communities and with the primary care, as well as our own vaccination teams in the community. So efforts are ongoing. I'm happy to bring an update on how the delivery against this strategic plan is going. But this season is proving to be a more difficult one than it has been last year. However, amongst the children, the seasonal flu immunisation uptake is a little bit better in our school-age programme. Thank you.
Thanks,
Great, thank you. Colleagues, further comments or questions? Winston.
Yeah, just a comment. I think some of the graphs associated with some of the strategic objectives are quite helpful, but some have ambitions on them and some don't. So it would be helpful to, if we had ambitions on all of them actually, because some you think, oh great, you know, we're exceeding our ambitions. For example, on I think it's page 8 of 10 of the report, where we're looking at nursing and midwifery staff in post, we've exceeded our ambitions, so that's a good thing to pull out. Whereas it would be helpful, for example, next to it, patients treated with dignity, respect and kindness, to know what our ambition might be on that one, if you see what I mean. Because then at a glance, then for a layperson or someone just quickly looking at it, they can think, okay, you're doing well against these areas and not so well against others.
Yeah.
To inform the discussion around.
Yeah. Very helpful. Chair.
Chair, there is more detail as well contained within the actual dashboard which sits behind the BAF, because we just lift off the higher level. So we'll look at if we can pull a little bit more information from, because there's a whole, as you can see, dashboard behind it that we just lift off bits. So see how we can improve that for you, Winston.
Thanks, yeah.
So the thing I would say is I'm heartened to hear that there's a kind of, that as we think about the broader strategy, we look to refresh strategic objectives, because I think they could do with being refreshed and kind of slightly tightened up and a bit more focused. And then it does feel to me it's really important to be able to align all your activities and actions under those strategic objectives, and to cluster the kind of effort and performance of the organisation to each of those objectives. And I think if we can look to refresh that, at least assure ourselves that we're delivering the right approach, I think that would be really helpful.
Yeah.
Great. I'm not going to, because of the timescale, I'm not going to propose that we take this item any further at this particular stage, and that we move on to our next item, 3.6, which is improving people and community experience. Sharon, I think I'm going to turn to you.
Diolch, Cadeirydd. Am y gwaharddiad i dangos y papur gwella pobl a profiad cymunedol yma. So thank you, Chair, for allowing me to present the Improving People and Community Experience paper. So, in summary, the report provides a summary of patient feedback activity from the beginning of June of this year right through to the end of September. If you look at the statistics, it's a slightly shortened report, but during this time, we've received feedback from over 18,000 people who've communicated with the health board in respect of their care and their treatment. But to contextualise that, when we look at the friends and family test, where there were just over 13,000 responses, that only represents 15% of individuals who've actually accessed our services. So we need to continue to find ways in order to ensure that we hear the patients' and people's voices. As with previous reports, you can see that the vast majority of feedback has been positive. However, during the period, we did receive a number of complaints and concerns, which presents an opportunity for us to learn. One area of focus mentioned within the report is the Ombudsman letter from the last financial year, which is detailed in Appendix 2. And it relates to the timeliness within which responses were provided, which was the main factor for driving the Ombudsman's interventions for case referrals. So throughout the year, we have been working hard on our timeliness of responses and have been able to consistently show that we are now closing more complaints each month than we actually receive. So there's making good progress in relation to the backlog of complaints that we had. And we are monitoring this through the escalation meetings as well. We've also put a lot of focus on improving the number of concerns and complaints that we can respond to as early resolution as well. So this is ultimately improving the timeliness of our responses, and is demonstrating a reduced number of complaints that we actually have to take through the formal putting things right process for investigation. And early indications is showing that this is actually having quite a positive effect. We're also making progress with the percentage of concerns that we're able to respond to within 30 days as well. So when I last presented this report, we were responding within 30 days for 64% of cases. Last report was 78.43, so the sooner we can respond, the better. And I have to say that the level of engagement that we're getting from our clinical services is improving and will hopefully continue to improve as we go forward. Within the report, we've included links to 7 stories in the report, and I want to thank all the individuals that took the time to provide this valuable feedback. We bring these stories directly to Public Board with the purpose really of providing a human perspective on the healthcare delivery and to make sure that patient experience remains at the heart of our decision making. The intention of the stories is to bring a personal dimension to the data and to illustrate the impact that our services have on individuals and the importance of compassionate and patient-centred care. The stories that we've included highlights both strengths and weaknesses in the systems, offering direct insight into what works well and where improvements are needed. This provides opportunities for innovation and change. So sharing these stories here today demonstrates our commitment to listening to patients and acting on their feedback, which will help to drive improvement and ultimately demonstrate that we value incorporating the patient's voice into our governance arrangements. So I just want to feedback on a workshop that we held on the 31st of October in preparedness for the revised Putting Things Right guidelines that we're expecting to be published next year. We had good clinical representation at that workshop, and we also had presentations from the Ombudsman herself, Welsh Government, Welsh Risk Pool and the Once Wales Civica service as well. And we did receive very positive feedback around the processes that we have in place for claims management and for learning from events as well, and also with the work that the Listening and Learning Committee is doing. So you'll note from the report that I also reference a new National People Experience Framework that's due to be published in the new year as well, which will improve the way that we can capture, respond to and learn from people's experience, and will provide some consistency across Wales as well. And one key area of this framework will be how we evidence learning in response to the feedback and how we continue to improve and convey those improvements to our population. So this then, together with our own charter for improving experience, our learning framework that is due to be presented to the Quality, Safety and Experience Committee in December, and the updated version of Civica that'll be hopefully presented in the new year, we'll be able to consider how we use the data and how we analyse the information to help us make decisions, target our resources and how we engage in a more meaningful way. So reflecting on this and our existing arrangements and the opportunities that will come over the next few months, there is an opportunity for us as a board to review the purpose and the approach for including the patient's voice in our assurance work and our reporting arrangements. Thus, I'd like to propose that with the chair of the Quality, Safety and Experience Committee, we progress this approach over the next quarter and bring a proposal back to board in the new year with a view to launch a revised report format for the new financial year going forward. So with that, I know that there is the Ombudsman letter as well that we just need to take account of when we come to the recommendations section, but I'm happy to open it to discussion, Chair.
Okay, great. Thank you very much, Sharon. Anna, would you want to add anything to that?
What she said, really.
Okay.
Sharon and I have had a conversation offline about the timeliness of looking at how we provide assurance to the board on around the inclusion of patient voice in our work, and so Sharon has described how we propose to do that. So with the board's support today, we will go ahead and then come back to you in the new year.
Great. Okay. I think it's absolutely imperative to get the rhythm right, because it should be. We can't dislocate this from everything else that we discuss. It needs to be a reference point for us whenever we're thinking about any other service portfolio or change we're thinking about. So I think the more that we can integrate that, the better. It's disappointing that we're still only capturing, I'm sure we're inviting and we're proactively encouraging people to respond, but we're still only capturing a small number of those responses, which means that often it becomes very binary. People who are highly delighted with the service or people who are not delighted with it at all. What is difficult to get is the stuff that's in between that. Yeah, and I think in the report, I think the other observation is
a lot of that feedback is coming from our front door areas, so A&E and outpatients, and therefore we need to do more work in terms of how we can capture the experience of inpatients, but also other people within our communities as well. We've started some work in primary care, but there's more to do in that space. Yeah.
I think that would be invaluable, because I think the way people self-define as a patient or as a citizen is completely different, and actually a very different perception of what the health service should be in those circumstances. So I think the more that we can sophisticate our understanding of who is it we're asking and why, the better. Yeah. Delith.
Yeah, thank you. And I was going to ask about how we compare nationally, and what kind of exploration you have, especially looking at children and young people. We've got Glangwili with no friends and family feedback from Kilgerran ward. So it's interesting where we're actually having that information from. But how much work are you doing with Llais in particular and the voluntary sector in gathering that feedback as well?
I think that's a good observation. It's disappointing that there is no feedback there from paediatrics, because historically we do get feedback. So we have scaled back the report, so we need to have a look and see whether we can capture that better. We haven't formally had a conversation about how we capture. I know Llais provides some feedback to us in terms of their surveys that they conduct with the population, but I think as part of the revised approach going forward, we could probably formalise that and make that more proactive, so that we have more of a joined up system-wide approach to capturing this feedback and acting on it.
Great, okay, thank you, Sharon. Eleanor.
I've been looking at the two Wordles, trying to make sense of what they're telling me. Microphone. Trying to make sense of both the Wordles to me. And it's reflective of my experience of going out and about there. The system is full of really good people doing a good job, who really care and are friendly and compassionate. But in a system that is struggling to cope, it's frustrating, it's causing delays, it's unnecessary. And I'm slightly reassured that they are telling me what I see out there, while still wanting to have a better set of responses that capture the middle ground. It's more of an observation than a question, I think. Yes.
Okay. Yeah, thank you. I think that's helpful, Eleanor. And I think you're right when we look at the trends and the categories for the concerns that we're getting. It's communication, but also access to service and complexity in communication. But yeah, it would be helpful to get some more meaningful data around that middle ground that you describe. Yeah.
It really would, because particularly when you look at the one in red, delays shows up, but there's delay, there's unnecessary waiting, delayed, and because the word is slightly different, if it was all the same, it would be shining through there, wouldn't it, about how much time?
Yeah.
Okay. Thank you. Yes, please, Michael, and then Rodri.
Thank you, Chair. Just looking at page 3, talks about the current percentage of concerns responded to within 30 working days as 78.43%. I was just reading across to the rights processes, and it does acknowledge that some concerns are always going to take that little bit longer. But there is an expectation that you can't reply in that time. We need to explain why, and to let people know when they can expect the response. So for that approximately 21% that don't fall within that 30 days, are we as the norm getting in contact with those individuals to let them know why we've been unable to respond? Obviously there's a day that we won't respond, we advise working the system, which we don't necessarily know.
Yeah. I think that's a good observation. The intention is that we would continue to communicate with individuals so that they keep informed of the progress that we're making against that investigation. But it probably relates back to the referrals that have gone into the Ombudsman as well. I think it was 23%. So timeliness is that's okay.
Just hear Michael's question.
That's okay.
Okay.
So timeliness of response is really important, and keeping that connection with the individual is also important as well. So yeah, that is something that our patient service support services team are aiming to do going forward. Yeah.
Thank you, Sharon. Rodri.
Yeah, well, Michael has asked one of my two questions, exactly what I was asking just now. But the second one is kind of, from looking at the papers, it said it was agreed to extend the time frame from 2 to 5 days. Obviously, it's a 20% kind of that are dealt with at the moment. So by increasing to the 5 days, how much better will you be from a percentage point of view?
So I think we've already demonstrated that in the report, in that we've improved the early resolution. It gives you, by the time the concern comes in and you're able to respond to it, that 2-day time frame was really, really tight. Yeah, so extending it to 5 days still keeps it very current and very relevant. But the new putting things right guidance is going to extend it to 10 days. So our approach was to do it incrementally, really. So we've extended to 5. We should extend to 10, which will then allow us to hopefully resolve a lot of more concerns in real time, rather than letting them go into a more formal investigative process, which then takes a lot more time.
The question was perhaps why not go to 10 straight away? But yeah, that's happening in January.
It is, yeah. We did take it to Quality Safety Experience, and we agreed that we would start that in January. Yeah, thank you.
And clearly, I'm going to come to you now, Joe. Clearly, the continuum between what we might consider to be a minor complaint and what becomes a major complaint is enormously wide in that space, isn't it? Which were a higher degree of intervention, investigation, structure required at the top end, and something very different at the bottom. Thank you. Yes, please, Jill.
Yes, thank you. Just wanted to recognise the patient story, which came from the Amon Gwendraeth cluster, very much around pain management and people's experience of that. And I think it goes back to our strategic conversation really around how we shift services and resources in the community. But I was just, again, picking up the issue around probably the lack of primary care and community information in this report, and we have in previous reports had some of the Civica reports that are being piloted through our managed practices, which I would hope that we will be able to bring into future reports. But more broadly, and it may be that we can join it up with your next report, Sharon, there is a national patient survey that runs contractually across all of our practices in the early part of next year. All practices have to participate in that, and it gives some very extensive information about people's experience of their primary care services. But perhaps we can join that into your next report, Sharon, if we've got the information by then, so that we do bring the breadth of that experience from primary care into this report as well. I'm sure we'll take it through our Quality and Safety Committee also.
Great, excellent. So we'll wait until January to kind of understand what that model is going to look like in the future.
Yeah.
Very good. Okay.
Yeah.
Before we move on from this item, we need to just note the Public Service Ombudsman's letter 2324, in which they request that their letter is presented to this board, so we all have sight of it, and also that we provide a copy of the annual report to the Ombudsman, and they would also like sight of the outcomes of our conversation here today, in terms of our approach towards understanding how we manage patient complaint inside the organisation. Final thoughts.
It was just to confirm, Chair, that so the first 3 actions have been completed, and then we will take forward the 4th action following today's discussion.
Very good. Yeah. Okay. I mean, it feels as if there's lots of work taking place inside this space, which is helping us understand where our services are falling short, or indeed they're being well received by patients and the public. I have a sense we've got further to go along this route, and I'm slightly minded. Per 1,000 head of population, we have the highest in Wales amongst health boards. So there is a question for me about why is that happening here more so than anywhere else. And we need to, the purpose of this data is for us to understand more and then to take appropriate action. So let us return to this in January. for a fuller conversation. Great, okay, thank you for that. Can I move us on to item 3.7? This is, Lee is going to lead this, this item. This is an update on a healthier Mid and West Wales strategy, and before he begins, just to say, originally in the meeting planning process, it was an item that focused upon the clinical services plan, and the more we tried to understand the clinical services plan in context, the more we needed to think more broadly about the wider strategy and the fact that probably we need to think seriously about strategy refresh. And challenged with that Herculean task, Lee kind of, in my view, managed to pull together a paper which I think it's an excellent paper in understanding the context and the environment, the landscape, the kind of issues, the contingencies, the impacts that we are experiencing in our day-to-day delivery services and held are, that we now need to think of in the context of identifying how we move forward strategically. So I'm going to ask him to present the paper, and then hopefully we can have a strategic conversation about how we think we're going to move forward in the future.
Diolch, Cadeirydd. Thank you, everybody. So one of the key tasks of us as a board is obviously to set the strategic direction for the organisation. We have a strategy, and I'll come on to that now. But the paper, I think, tries to provide a very honest and frank assessment of the position with the strategy and the broader context within which we're developing plans, and of course the implications of that for our health board services and models. It includes, as is referenced in the paper, an update on the clinical services plan and an update on the primary community strategic plan, both of which are complementary components of our strategic roadmap as it's developing. The paper, you'll have seen, covers a great deal, and I know board members will have read it in detail, so I'll not attempt to cover all aspects. I will, however, summarise just a few points to frame the discussion. So the starting point, really, in terms of context, is that we are in a part of Wales where health services have been challenged for decades. This isn't an immediate issue that's just arisen, particularly around significant workforce pressures, service fragilities, and as we've already talked about, financial deficits. Board members obviously know that in 2018, 6 years ago, as part of developing the strategy, we were clear that this position was unsustainable and radical change was required. Since that point, we have, of course, had the pandemic. We've seen a lot of change, and the paper references some of those things, and we've seen some progress in some key areas. So the work on nurse stabilisation we referenced earlier, development of some of our community facilities, and so on. Despite this, it is necessary for us to acknowledge that the services that we were concerned about in 2018 remain unsustainable and arguably are more fragile in some cases since that time. Our estate remains not fit for purpose, and the paper notes that our backlogs have actually increased over that period. And of course, we have seen demands and challenges grow post-pandemic, which we've talked about some of that already today. At the same time, we've, I guess, increasingly come to the view that a new hospital is realistically now at least 10 years away, and the totality of the capital investment that we set out in the strategy, which was not just the hospital, it was also repurposing Glangwili, Withybush, the network community facilities and so on. The totality of that investment in the time frame that we originally anticipated now appears increasingly unlikely. So when we look ahead and consider the wider context, I think it's also important to recognise that we are entering a period where we expect the need for health services to grow year on year for the next 20 years or so, as we see our older age categories increase, the population increasing in those older age categories, whilst at the same time our working age population is expected to reduce. There are some fundamental challenges that we're going to need to think about, and we therefore need to be in the best shape possible as we enter that period. The paper as you'll have seen, considers the implications of these realities for our strategy. In general, we anticipate that the core principles within the strategy remain valid, and we've talked about some of that already today, but the route to achieving this will likely need review, both in terms of the long-term future models, the direction, but also the short and medium-term plans for the interim. So building on the clinical services plan work, which obviously is set out in quite some detail in the supporting paper, we've started to outline what this could mean for our hospital sites, building on the strengths of each of those hospitals, which the board will likely want to test more thoroughly through wider staff and public engagement. That's just a starting point, but it's helpful to frame those considerations. And in conjunction with that, with the CSP, work has been progressing on the strategic plan for primary and community care, which is also provided as a supporting paper and provides further detail on our thinking on that. And of course, that was central to the vision that we set out in Health and Mid West Wales. So finally, I know as a board, we are very eager for our staff, population and partners to help us shape the design of future service models, and the paper concludes that alongside anticipated public consultation and engagement on the clinical services plan and the primary community strategic plan, we should also consider the need for the wider strategic refresh that you mentioned there, Chair. So with that, I'll move us into the discussion. That's okay.
Thank you very much. Irie.
Diolch, Cadeirydd, and thank you, Lee, for writing a very detailed and detailed paper about the reason we are where we are and the continued need to change our services. The reasons the strategy was developed and finalised in 2018 haven't gone away. The fragility of our services, if anything, have got worse and more acute. And today we've been hearing about the tensions between meeting our financial constraints and not just maintaining our current services, but looking up and improving them and having ambition to have world-class services. I think we're in a position which is unfortunate. We have to deal with the financial constraints and the changes in what's been happening over the years of the pandemic. The strategy remains sound. The ambition to move things more out into the community remain, but we still have to deal with the secondary care, the acute illness, and instead of having to do that in our financial constraints in a bad way, we need to look forward and develop an ambitious way of managing our secondary care facilities, and we have to make changes. Those pressures haven't gone away and they've got worse. So I think we need to really refresh that strategy, bearing in mind where we are in the financial environment, and with ambition to make things, not maintain them, but make them better than they have been.
Thank you very much. Very helpful. Michael.
Thank you, Chair. I think that's, as people have said, it's a very helpful paper, very well written, and I think what it shows us is that our ultimate strategy was predicated on a new hospital. In a way, we've had to kind of park the car for a minute and revisit the landscape. And I think that's very, very transparent and refreshing that we are saying this. The point I want to know, and perhaps it's buried in the detail, so forgive me if it is, but in terms of a strategy refresh is what the kind of closing line is what is a timeline for that? Now, I appreciate that's a big deal, a strategy refresh, but it's important because we don't want to be parked at the side of the road for too long, because our communities and our partners and our staff, everybody needs that kind of that route map. And if we are revisiting the route map, we've got to get on with it, basically. So just it's timelines, I think, is my concern, Chair.
Great, thank you. I think we'll come back to that, because I think that's where we need to end up in terms of our conversation. A good point. Irie, do you want to come back in?
Yes, can I echo what you're saying, Michael, as well? 2018, we were faced with a fragile bunch of services and they've got more fragile, and we're at risk of seeing those fragile services fall over and tip over in succession, and us having to react rather than act in a planned way. So I think you're right, you know, we need to get on with this quickly and in a managed way so that we stop services falling over, but we develop services that are safe.
Right, so what I'm taking from your messages is there's an urgency about the refresh and kind of looking at where our position. We can't navel gaze over this issue. We need to get on and sort it out. Very helpful. Jill, you look as if you want to come in?
Yes, I think I do, because I think the points that I raised are equally important in terms of primary care, and the demand is significant, and we have really critical issues around our estate and our workforce. And I think what we've signalled in this paper, which I very much welcome in terms of joining up all of the elements of our plan so that it's seen as an integrated whole, is some of that sort of service model that we've got to consider now for the future. And what we are attempting to do in the next phase of the Primary and Community Services Plan is very much around those principles that we would want to aspire to. And I think the difficulty for us is how we transition that planning and service modelling into reality, because there are some big aspirations that we would need. Now, not everything's about new money. Some of it's about how we develop our workforce or shift our workforce in terms of some of that activity. But we do have to make some of those plans, because we've talked about the primary care model for Wales for a very long time, and we now need to set down some really tangible things that would get us to work differently. And I think that's what we're attempting to do now in the next phase of this, so that when the board is facing decisions, whether that's about resource or workforce or whatever, we've got a set of aspirations and models that we would work towards, and that would help inform the board's decision. And, you know, we've tested one of those in terms of list size for practices, so that the next time we're revisiting some of those big decisions, how would that principle inform the future? So I think we're up for this. There's a lot of resource out there that we need to think differently in terms of how we use it. And I think you referred in the very early stage of the meeting, Chair, around the opportunities that we've got to spend the resource we have well against the strategic principles that we're setting. So I think for me, the next phase of this plan is going to be quite critical in setting down some tangible points around the model that we're working towards.
Thank you, very helpful. Diana.
Diolch, Bwrdd. I just want to draw our attention back to the Mid and Health West Wales strategy, which is not just clinical services strategy. We don't exist as a health board just to provide health services. We exist as a health board to improve the health of our population through delivering health services, but also other mechanisms. And I just want to be very clear that within that strategy, we have to be focused on how we are going to deal with all these points that Jill make very eloquently with fragile services, that we are not going to cope. We are not going to cope unless we are very clear in the strategy that we are going to improve what we do in preventing ill health and what we do in helping our people stay well for longer. We are committed to a social model for health. We are committed, and we've got obligations to deliver preventative services. But through that refresh of the strategy, I really will want to see that we are very clear in our ambitions and determinations in those aspects. Diolch.
Well made. I'm going to come to you here next. Well made, because there is something about the fact that if we want to develop and kind of grow and mature this strategy, we have to come to it with a different head than we did in 2018. So we have to recognise the accumulated wisdom or knowledge or experience that we've developed over the last 6 years to inform us as to what we think should happen in the future. And that will be the difference that makes this strategy much more pertinent and relevant to the future that we're trying to deliver. So it's how different have we become over this period, and what do we think differently about the future? And I couldn't agree more with the very fine balance we need to strike between building and creating a healthy population, facilitating that population, and at the same time ensuring the services we provide are exemplary services. Great. Hugh, and then, yes, please.
Yeah, thank you. I really picked up an issue in terms of finance being a constraint for us, and I understand that sentiment, but I don't think I've heard anything that persuades me differently that our financial deficit is purely a consequence of waste, harm, variation, fragility, workforce, design of services issues, all of which are within our grasp. So they are all areas that we need to address as part of the strategy that will have a financial benefit for us. So it's fundamental for our long-term sustainability for us to address.
That's very helpful, because I think you've just created our checklist of ways in which we can assure that there's quality underwriting our strategy in the future. There are things it absolutely needs to do as we move forward. Great. Donna, do you want to...
Diolch, David. A pob clod yw awdur y papur hyn, mae'n papur enfawr, so thank you, and do credit to the author of the paper. It's a very detailed paper. It combines a lot of detail, but it is also out there in the public domain now, and it's there for the public to see. And whilst I appreciate that the board has to look at financial implications, estates and strategy, for Mrs Jones in Cynghordy, who's worried how she's going to get her hip operation or where that's going to take place, how this translates into information for the public is really, really crucial. There will be members of the public that will be concerned about aspects of this. Some areas of our population live the majority of their lives in their very small villages. So, for example, you know, Mrs Davis in Pontyberem may live 98% of her life in Pontyberem, and the thought of having to travel to a hospital she's never been, to a town she hasn't been to for many decades, leaving behind or having to organise caring responsibilities for a disabled husband or for grandchildren, that is going to be one of the biggest worries that people have. Quite commonly, when people approach us in Llais and they have any planned treatment, the first question they ask is, where's it going to be? They're not worried about the length of recovery. They're not worried about who's doing their treatment. They're not worried about actually what the treatment is. But it's how they're going to get there, how they're going to get there on time. Are they going to get there and find their procedure has been cancelled when families, etc., have maybe booked leave, made arrangements to provide the care facilities? So in terms of how this strategic document pans out to the public, we ask that a lot of attention is given to that. I think very much back in 2018, the public received Tylee Jones really well. The public are not necessarily going to read detailed documents, but if they are given examples of somebody who is like them or similar to them, that will stay with them, and we need that information to be shared across communities about how things will happen. We had it happen with the major trauma changes. That was quite a difficult thing for the public to understand, but the use of the Tylee Jones and the story that was given there meant people could understand the pathway. So whilst we appreciate the need for strategy to be looked at, we appreciate the forward direction, the need to look to the future and to fill the gap that there's going to be until we look at this new hospital, if we can please bear in mind at the forefront of everything that we need to make sure that people understand what is happening and what it means for them, and we'd really appreciate if that is given quite a considerable amount of attention.
Great, well thank you very much, because I couldn't agree more with your view. I think it's about the felt experience of this service as well as what's delivered as part of it, and I think we should always be aware of Mrs Jones, you know, and reference Mrs Jones, Mr Jones, whoever, in our work as a critical point of safety, effectiveness in the way in which we're delivering our services. The thing I would offer, I suppose, because I think there's some way to go down that road as we kind of start to rethink what this strategy is about. The thing I would offer is that we can't create a strategy in a back room, you know, kind of just by ourselves. We need to be talking to the people who will matter in relation to that strategy, not just in terms of recipients of services, but those with whom we will co-produce and co-deliver those services, which is largely the wider community as well. So there's lots of things that we need to do differently in the way in which we move this forward, and I think we will have to do that in a consultative forum. And I think the challenge for us will be to create a way of engaging with the wider community that's meaningful and authentic, and which they trust as a direction of travel in terms of coming up with what we think is the revised or refreshed strategy. So I'd offer to you an assurance that that's the journey we will take in relation to this work. And therein as well, I would say, Donna, there's a change to the way we all think about these services. You know, there's a change to how we, as kind of the provider community, think about the services we provided, but there's a change within the wider community as well about how it receives those services and what it contributes to those services and the way in which those services are delivered. We cannot continue to think about our services the way we have done over the last 30 years and think somehow that's going to produce something different in the future. We all have to shift in terms of our perspectives and how we develop and deliver those services. And I think this paper is a fantastic starting point for us to be provoked into thinking about that. The thing you haven't said that I think is important, and others haven't said, is there's an honesty to this paper which is really important for me. We have had conversations since I joined the board, which is not that long ago, about the new hospital. Indeed, I remember conversations about new hospital 20 years ago. And it's a bit like it's been there as the issue. And I think it's about time we were really honest about when we think that is likely to happen and start to build our strategy that's not predicated on that building and those beds, but it's predicated on working with our communities in a very different way and delivering quality services in a very different way. For all the reasons you've said, Hugh, you know, this isn't a fanciful idea. This is an idea that's actually going to move us to a different kind of organisation and address some of those fundamental challenges we've been facing every day in terms of delivering our services. Our fragility, our cost, our location, all of those things will need to be embedded in this strategy. But I think there's something about the honesty of this which reassures me that we can begin this journey and refresh it and bring that honesty to the conversation. Eleanor.
Diolch Cadeirydd. You have said, you and Donna have said much of what I was going to say, so I'll just do the additional points. Thank you for a really good paper. I think this is a start of a very good public and need for a deep public conversation with the population of Hywel Dda, and that includes our staff as well as the population there, because it will be a very different way of doing things if we keep going down this route. It addresses for me the need to link up the primary acute public health messaging so that we start on that journey towards getting the right treatment in the right place at the right time, balancing by actually what we need to develop is quality services, which may not be the nearest place to where people are, but they will be quality services. And it's a very difficult balance, as Donna highlighted, between wanting a service, whatever the service is, near where I am, to having the best treatment I can possibly get. So I think it airs that. It also airs for me some risks that go to the trust to the health board. The risk of actually having to make unplanned changes and then nobody understands why we're making them. It also makes us think about when we make temporary changes, make sure they don't become unintended and stay in that way, that we make conscious decisions about things. The context from 2018 to 2024 has changed enormously. The health board, everybody's been through COVID, the politics is different, the financial circumstances are different, the cost of living crisis is different, which to me points to all of the things that we've talked about being brought together to a new strategy that goes 24, possibly the next 10 years, taking account of the big stuff and Mrs Jones in Crubin and Mr Williams in Ponteberem and wherever they are. It's all part of it, and it's a co-productive conversation that's really important.
Thank you, Eleanor. I think that's well kind of captured. Anne and then Anna.
Thank you. It's reiterating quite a lot of what Eleanor's just said, but more on a staff focus. From these papers, at the moment, everything is clinical service plan, but this identifies the public health, the primary care, then it should be the clinical service plan. And we have fragility, we know that. And from the way this paper is presented, which is so frank and honest, is that this is what we need to do. But it's for the staff to understand that there's three elements to this: the public, the primary care, and then the secondary service. And out of the secondary service, it's the fragility services that we're looking at, and the underlying element is the regional services. So it's, like Donna says, it's making the staff more aware and not assuming, because they're clinical, that they know what we're talking about. Because when Jane goes to work, she just does her area and field. So she wants to know how this clinical service is going to be in that triangle. So it's the communication with the patients, but communicating the staff in that similar field, please.
Well,
Thank you.
completely. I am going to come back to you, Lee, once we've taken a few more comments, in case you have any, and then I'm going to come to Phil as well. Anna.
Thanks, Chair, and thanks, Lee, for a really fantastic paper. I think it's really helpful to see it so clearly and straightforwardly and honestly set out. And thanks to Donna, too, I think, for a really powerful contribution. And if I might add to that, there are Mrs. Joneses sitting around this table, too, or at least people we love and care for are affected, too. So I think that's also important to ground us. These are conversations that affect us and our families as well as the public out there as well. If I might make a couple of comments from a quality and safety point of view, I think the first is, sort of some couple of key messages I take from this. The first is that I think there is rarely a quality committee that goes by when we are not considering at some point in its growing fragility a new service. That sort of hopefully gives a sense of the scale to people who may be listening to this, that this isn't a small number of isolated situations. This is a pattern that is as a consequence of the configuration of our services for the population we serve. And so this problem is not going away. It won't change. And that fragility is sometimes usually about services we currently provide, but it may also be about fragility in terms of access to services we don't provide, or that we don't have sufficient capacity to respond to need with. So that is definitely coming through our assurance work on a very regular basis. And I think the second thing is that while we may not be where we hoped we would be in 2024 when we were thinking about this back in 2018, there is an enduring message that centralisation in modern super specialist medicine is an inevitability, and it's one that's hidden in urban environments, but in a very rural dispersed population like ours, it is right out there, and it worries the likes of Mrs. Jones in Pontyberem, and it should worry us too, because it is having an impact. It does have an impact on people's ability to access care. But I was speaking to a member of the public just yesterday who said to me, you cannot proceed on the basis of a corner shop mentality in the provision of healthcare in West Wales. And I thought that was a very prescient and sharp way of describing exactly the risk that we will run into if we don't do those brave and courageous things that we know as a board have got to be faced with our population.
Thank you. Really helpful. Maynard.
First, thanks to Lee for what has been an excellent paper. And the communication side of things, I think has been expressed already, so I won't go into that. But, and we've touched on it, but I think earlier in the meeting we talked about regionalisation. And
Maynard, just pull it to so we don't miss any words.
Thank you. Regionalisation, and that is another thing that has really changed in the 6 years. The emphasis on regionalisation and centralisation of services for excellence, I think, is absolutely key. But the thing I wanted to add is, and it's mentioned in here, is the digital aspects. That has moved on incredibly in 6 years. And I think that has an ability to deliver services into people's homes that we've never experienced before. It's, with my other hat on as an older person's champion, there are restrictions in that because not all older people have access to the internet and all those things. But I think the role of things like AI in diagnostic work and the actual being able to monitor people's health in their own homes using techniques we're already using in the health board is absolutely critical in when we look at the new strategy, revising the strategy and the way we deliver it. And the final point is, I have concerns about the state of our estate. We have buildings, Glangweili in particular, which are not fit for purpose in delivering modern services. And we have to find a way around that in the next 10, 15 years before the hospital is delivered.
Of course, great. Thank you very much. I think you emphasise how much what we're trying to do is to think about a future strategy that is predicated on so many things that are evolving quickly inside our environment, from our digital AI applications to the way in which the service models we're using, to the population, to the aging population. All of those factors, to the economy itself, are all evolving so quickly, and we have to somehow be in that place to be able to respond. The other thing I'd say, and I think it links to what you said, Anna, which is there is something about being brave and courageous in relation to this strategy, because it's going to be a bit of a painful journey. We sometimes imagine it's a journey towards pleasure, and incrementally we will be pleasured throughout the journey as we move forward. Well, that ain't going to happen, because there's some really tough, difficult things to happen inside this space if we want to get to that end result. What we have to do is be all agreed as to where we're trying to get to, and not just within the health board, within the wider community as well. Have clarity on what it is we're trying to achieve as we embark on that journey. But point very well made. Okay, Chantal, I'm going to come to you, and then if there's nothing more burning, I'm going to come back to Lee and then Phil, and we'll take it from there.
It's just a quick observation. So when I was looking at the broad direction of travel, many of the ideas set out in the paper, which is really well articulated, have been things that have been talked about for decades. And certainly over the last 50 years that I've been involved with the NHS. And I'm just wondering, how confident are we that, no, I think I should rephrase that. I said, if we do go down that particular road, we have to be able to demonstrate that there is some change and that there is some progress in terms of those areas. Because I think otherwise the members of the public are going to lose faith in the fact that we are saying we're going to do all those things, but we don't achieve those.
Of course, and I go back to my original point at the start of the meeting. Everything we do should be aligned with our strategy. But we need to have absolute clarity on what we think our strategy is inside this space. Otherwise, that's quite difficult. And there's no point at which we can sit down and stop. So in other words, even though we're in the process of thinking about how we evolve our strategy, we have to continue to strive towards delivering excellent services across a whole series of areas. The challenge will be to make sure that all those developments will align with where we want to go in terms of our direction, even though we're refreshing it. And I'm fairly confident we can do that. The clinical services plan is an example of how we need to address the fragilities around our services. But in terms of a strategy, we just can't be pushed into the strategy. We have to be pulled from the future. So it just can't be about, I say often to the chief executive, we're not designing a steam engine here. We're looking at something that's way beyond understanding what we're doing now to understand what it might be in the next decade. And that is our challenge, is to understand that picture and then to try and align the things we're doing today with that picture. Lee.
Thank you everyone for the comments. They're extremely helpful actually. And I'll just pick up 3 points in response to some of them. So on Anne's point, so I think it's really important that we're clear that the CSP is not the strategy. That I agree entirely with you. It is a component part of that strategic direction. And to take us back to the BAF conversation, the 10 planning objectives we've got are designed to all be component parts of that bigger jigsaw, if you like. So obviously you've referenced primary community strategic plan and population health, both of which are important. In addition to that, though, of course, as Maynard says, the digital plans, the workforce plans, and so on, and the 6 goals work, that they're all painting the picture of what that strategic direction looks like as we work towards that strategy. So they're all equally important parts of that strategic direction. I think Donna's and Anna's points, I think, are incredibly important in our considerations around this, and really frame some of the dilemmas we've got. So I would, when I think about it, as you say, Donna, Mrs Jones spends 98% of her life in Pontyberem. We want 98% of Mrs Jones' healthcare to be provided in Pontyberem, whether that is virtually keeping her health healthy and independent in her own home, or access to prime community services. When we think about the most complex parts of our system, our service provision, which are designed for rare life events, we want them to be at the highest quality that we can deliver, because that hopefully isn't required that often. But it does, I think, draw out the dilemma we've got in reality. And what I think the important first step is for us to be very honest in our dialogue with the population about that dilemma. We don't have the advantage of living in a very urban area where you can do both of those things without any kind of compromise. And I think, as you say, Chair, that is going to be a difficult set of conversations, because we won't satisfy everyone on that journey. If I could just add then, in terms of Michael's points, I don't think we have the luxury of putting change on hold whilst we work through the strategic refresh conversation. The CSP is an example of that, the Primary Community Strategic Plan is another one, but we will need to continue to deliver change as we're working through this in parallel. And I think it's also worth just reassuring people that we're not throwing the strategy out the window here. This is not a radical change of direction. This is a refinement in how we deliver that strategy. So next steps for me, which are just stepping into the sort of conclusions, are we've got a board seminar coming up in a couple of weeks where we'll have an opportunity to discuss this further as a board. And then I'd like to bring something further back to January board, so we can consider what that plan looks like alongside the existing plans that we've got for consultation for CSP, for example.
Excellent. Thank you, Lee. Bill.
Diolch, Cadeirydd. So I think Lee's probably covered most of the points, and I think we've had a really wide-ranging discussion on this, and I'm really pleased that it's been so well received. I think to be fair to our staff and the public, our timelines that we've described around the new hospital would mean that they would be expecting the hospital to be open by 2029. So this is a really important paper, an important moment. We have to accept that when you're at the stage of the business case process that we are at, a new hospital is going to be at least 10 years and maybe longer in arriving. And so that means that our planning cannot be based on a new hospital being there, as you've said, Chair. And we do need to take stock, given 6 years have gone by, and it's been a big 6 years, given the fact we've had COVID intervening, the amount we've learned about the projections on demography of our population, the amount of change and learning we're seeing around AI and tech, the fact that over 60% of our population are overweight or obese, and that's increasing, the fact of climate change, the advances around genomics. There are so many things to take account of. It would be wrong just for us to just plough on with just the same thinking. I think we have a slight dilemma in that we want the development and refresh of our strategy to be a very engaging process, both with our public and staff. And in fact, we want it to lead to something that we wanted before, which is much more continuous, earthy engagement with our communities. So I think that needs to be built into the process that we go through. The dilemma is that when you look at our clinical services plan paper, there are 9 services there where there are significant fragilities, and concerns and about how we deliver them in the short term. And we don't want to make urgent service change. When we make change, we want to engage and consult appropriately on that. But even with those 9 services that are set out, you'll see that some of them, I'm concerned, there may need to be urgent service change before we get to the end of the engagement and consultation. We want to manage that. We don't want that to happen. But we'll do everything we can to avoid that. But we are concerned about that. So there is that dilemma on those intersecting timelines. But I think Lee's right. We do have the opportunity to discuss our strategy at the board seminar. We'll want to bring some next steps, of course, to board back on the timelines and how, not just timelines, but just how we intend or would suggest we approach the development of that strategy and setting of new strategic objectives. But also in the paper, there's a recommendation about noting the progress of the clinical services plan and primary and community services strategic plan and endorsing the proposed next steps. And we just need to remember those, the context of both those pieces of work.
And I was just going to take us through those endorsements now before we close the item. Great. Okay. So thank you for your contribution to that. We will have many more of these conversations, and I think our ability to just try and stay in that strategic space, but keep our feet grounded on the stuff that matters to people every day will be really important. But we do have to be able to understand our strategic direction in the future. If there's any august body in this part of West Wales that should be trying to determine what this service will look like in 10 years' time, it's this body. And I often say to Phil and to colleagues generally, and I said it this morning, if we were to project ourselves into the future, where we've become highly successful in our ambition, and look back and understand what made that possible, what allowed us to get to that point, then it would be our ability to come together as a community and develop a strategy that we all share. It would be our ability to work with communities to take this agenda forward. It would be our ability to be brave and courageous when faced with many challenges that are going to surface and emerge along this way. So there's lots of things we need to grip as we take this agenda forward, other than just thinking through what we think the future might look like. So in terms of some of those things we would want to just endorse, are we comfortable in terms of feeling that we've had a useful strategic conversation about how we might want to move forward in the future? And are we also content with the idea that we now refresh our strategy in the light of changes as we currently see them? Great, I can see. And then in relation to the clinical services plan, Phil has obviously identified the fact that we need to continue to progress the clinical services plan because of the criticality and fragility of some of those services. So we can't afford to park this whilst we rethink the strategy. We need to continue that. And I think having reached the end of phase 2, what we would recognise is there's been some substantive and well thought through and disciplined work that's got us to this particular stage of the process. The thing I would say is, in relation to the clinical services plan, whilst I think it's important for us to be able to progress this, there needs to be a number of provisos built into that. Those provisos are largely that take into account this refresh and rethink about our broader strategy. So we want to engage, we don't want to find that we're engaging in activity around the clinical services plan that might undermine or alter what we're doing in that strategy. And the other thing I would say is, and I think a number of you have said it, we need to work with a regional agenda. So we need to understand the clinical services plan. We need to apply a regional filter to the clinical services plan to understand the kind of the population need for the whole of the region, and also work with our neighbour, Swansea Bay University Health Board, to think about our clinical services plan in relation to their clinical services plan. So let's see this much more as a collaborative enterprise there's been some very good work going on in this area. Let's strengthen that now with a regional lens and also ensure that it's going to align with the strategy we want to develop in the future. Is everybody comfortable with that? And then Lee, we will take as read the additional elements inside the clinical services plan as you presented them in the report, if you're happy with that.
Yeah, absolutely.
On the primary care and community strategic plan, which I think broadly lays out the process and the activity to date, I think we see good signs of starting to build and engage in that broader approach to understanding what that plan might mean. I think I endorse what you say, Jill. There's a need to plan as opposed to just think about that broader strategic element. We need to focus on the planning element, but I also have a view that this plan is going to be critical to that swing away from conventional health services as a secondary care service to much more of a primary care driven services. This plan is the bridge in my head towards delivering that transformation in the future. So there has to be a really strong strategic transformational element to this plan if we're going to be able to make this journey. Nadia, did you want to say anything? No, you just fine.
Thank
Okay,
you.
I'm just brilliant. Okay, is everybody comfortable with that? Great. Okay, I think this is a really exciting agenda. I think it's going to really help us to think beyond where we currently are to understand things differently in the future. And I look to all of your engagement and involvement in that process, and indeed the wider public, to be able to take this forward.
Chair, sorry to be so pedantic. Can I just check on the CSP item that there is an approval there in terms of procurement? So I'm assuming in terms of you're approving the whole,
Yes.
you're approving the procurement as well. Just wanted to double check.
Yes. Great. Okay.
Yeah, it's fine.
Fine. Okay. Thank you for that. Can I move this on? Jill, did you want to say anything about the primary care? You're happy with the?
Yeah, I'm happy with that approach. It's very much the integrated part of that picture of the way you described.
Excellent. Okay. We haven't forgotten anything inside that space. Can I then take us to item 3.8, which is an update on the Prince Philip Hospital Minor Injury Unit? Andrew.
Yeah, good Alodi, you'll recall that last board meeting we considered and made the difficult decision to implement an urgent temporary closure overnight of the Prince Philip Minor Injuries Unit. The paper that's provided today for board sets out an update in terms of actions that have been taken since that decision was made, and also articulates the process we plan to follow over the course of the next 5 months now, to the end of March, 4 months I suppose given the date, to the end of March, to bring back a short list of options. I think worth emphasising that we, following the meeting, the standing operating procedure was worked on and updated to facilitate the closure. The closure happened overnight as planned. And there have been no incidents associated with that closure reported to me since the beginning of November. We have seen a significant improvement in our 4-hour performance, so those patients accessing the service are now being treated, 96% of them as opposed to 81% of them have been seen within 4 hours, so that feels like an improvement in experience, and we have only had 2 12-hour breaches compared to the circa 90 on average we were getting every month prior to then. So there are some significant benefits, I think, in terms of experience and access from the changes we made, and the long waits there were obviously part of the concern, particularly overnight, that the staff had raised when they asked us to take the decision and consider the action we agreed to. We have established a steering group and project group. The steering group is chaired by the medical director, with the Director of Nursing, Patient Experience, Safety and Quality as the Vice Chair, and we have a project group that the Hospital Director for Prince Philip and Glangwili, Dr Gosel, chairs. Our intention, and we're meeting on a regular basis, we have, as in attendance members of that group, both Llais and members of the Save Our Services Prince Philip Action Plan group, the SOSPAN. And our intention now, as we work through the coming weeks, is to follow the same process we followed for the review and development of options for acute paediatric services, which would take us to a point whereby in March we'll be in a position to present to the board options for the future model. I think there are a couple of risks that we've identified in the paper, not least the fact of the impact of Christmas in the coming, when it does in that period, and the pressure that could put on stakeholder involvement and service engagement. The planning capacity we've got in the organisation to support the work with all of the other activity that we've just discussed as well that we want to commence and push on. And I think just to stress that we've tried to make that timeline as rapid as we possibly can, obviously to make sure we can come back in March with that short list of options. So I'll pause there and open to any questions.
Thank you, Andrew. Sharon.
Thank you, Chair. Thank you, Andrew. Not a question, just to build on what Andrew has just reported, really. I've had feedback from my nursing colleagues because some of the concerns that led to our decision was raised by nurses, and the feedback has indicated that the redirection protocol is working very well, that they are now working within the scope of a minor injuries unit. The feedback from staff is positive currently. Although attendances have dipped, there's been no obvious impact on Glangwili or Swansea Bay that we're aware of at the moment. And for mental health patients, the 111 option 2 is working well also. We've agreed with the chair of the Quality, Safety and Experience Committee that we bring a more detailed report in around incidents, complaints, concerns, just to make sure that we are scrutinising those as we progress through the next 6 months. So we'll bring that to committee in December.
Great, okay. I'm going to come to you now, Donna, but I mean, it would be really useful to understand whether there's been an impact at Glangwili or Morriston in terms of people attending those sites instead of coming to the minor injuries unit, and perhaps we could have some data by then, or you will have some data by then to be able to understand if there's been a change or a difference.
Okay, we'll work on that. Yeah.
Donna, and then...
Yeah, just a comment from a Llais perspective. Obviously, people will come to us sometimes when they want to raise a formal complaint about an issue. Sometimes they come to us just to tell us their story, so they feel it's been logged with somebody. We haven't heard anything in terms of any patient dissatisfaction in relation to the overnight closure yet. And obviously, if we do hear it, what information we do hear, we will share in an anonymised format so that it informs any future decisions about the future of MIU and PPH.
Yeah, we are always keen to understand those, to hear those voices and to know that we can respond to them if at all possible. There's a few people want to come in. Michael, did you want to come in?
Yes.
Great, Michael, then Maynard, then Dalith.
Okay, thank you, Chair. Yes, this is an area where I actually, 11 years ago, actually, as a lawyer, acted for SOSPAN, suing the health board. So I got a kind of hopefully a perspective on both sides.
Dodgy history.
Yeah, an honourable history. And so I'm very pleased. I was interested in these steering group and project groups composition. Very pleased to see Llais involved, SOSPAN involved, and GP clusters involved. I thought that was very, and staff involved. So that's all very good. I was just curious though. One of the big issues exercising the good people of Llanelli is transport issues. So would it not be possible to have somebody on that committee who is a transport guru of some sort, knows bus timetables and train timetables, back to front, inside out, in their sleep? And also, the other question was, what about our regional partners, like the local authority, someone like that? And finally, I think sometimes, I'm sure, I'm very pleased to see the rate of progress so far. But perhaps part of the answer might lie in an entirely different perspective of how to make the service sustainable, return it to its pre-temporary closure position, possibly. All options must be on the table. So again, is there room for some kind of, I don't know, external thought process, somebody with external ideas, fresh ideas, radical ideas? So it's, I think the composition of these groups is going to be critical to what the outcome will be.
Okay, so helpful. Andrew, do you want to respond to that before we...
Yeah, I'll have a go at response to that now. So I think the points you make around membership are issues we have discussed as part of the executive steering group. Our view was that they were certainly individuals that we would want to engage as we're working through the conversation. I will take back, though, from the meeting today back into that, just whether we want to consider a more formal arrangement in terms of their engagement on the group. But they were certainly areas and important stakeholders that we felt we needed to talk to. I think you're absolutely right. We've been clear through the steering group and the conversation so far that no options are off the table. We're starting and getting the long list before we get to a short list. And we've certainly encouraged the team so far to look outside of the Health Board and across Wales and the UK at other models that might be relevant to what we're trying to achieve. I certainly think there are models, and I was fortunate enough to see one last week, whereby there are ways of creating a system which builds on existing streaming hub ethos that we've got, that would enable us to direct patients to the most appropriate service in a scheduled way, and almost start to transform the whole concept of unscheduled care from being unscheduled to being far more planned and scheduled, and give a much better experience. I know that's something that's very much in their minds anyway, because it was something that was on the table, but there's in the context of the previous conversation as well, I think there's a lot of scope and merit in us exploring that much further as we work through this work. So this becomes, in some ways, for some of that earlier conversation, this becomes a little bit of an early test of where that might take us as a discussion.
Great, okay. I'm going to take a cluster so that we can pull this item together. Yes, please.
I may have missed it, but I could not see Swansea Bay represented on any of these groups, particularly as Marston is the closest A&E department to Llanelli. I think it's fairly crucial that they should be represented there. And the second point to raise is, in the risks, it mentions planning capacity. And I'm just worried about that, particularly at the time when we're trying to put our annual plan together, that if we've got too much planning activity going on, whether we've got enough resources to do things properly.
Yeah, okay, so 2 assurances needed there. Hold on to those. Let's find out other comments. Stella.
Diolch, Cadeirydd. It was just the issue about the impact on our primary care colleagues. Is that data being captured as well as the other data for our Gangwili and Morriston? I think initially some patients might have gone to minor injuries where they should not have been, because there was an issue about education about a minor injuries unit. But I'm just concerned that there might be an indirect impact on our primary care colleagues.
Okay, before you come in and answer that, other questions? Eleanor.
We said when we met the public and when we met the local councillors very clearly that this was a temporary closure whilst we considered options. I just want to say that explicitly today at the board, that restoring it is one of the options that will be on the table, because we don't want to drift, as Leaf's paper identified, into temporary decisions becoming permanent because we don't make conscious decisions about them.
Yeah, I think we would all endorse that. Yep. Andrew.
I'll take those in reverse order probably, and maybe give Lee the opportunity to comment on the planning capacity, because I'm conscious I'd be talking about his team there, and that might not be the right thing to do. So I think I completely agree with the point the Vice Chair has made, Eleanor. That absolutely has to be the situation. And just to support that, one thing I should have mentioned in my earlier update is, following the board, we did place another advert and are still seeking to recruit GPs into that service and exploring opportunities when we get notified of people that might be interested in seeing how we might develop that further as part of that solution. So that is definitely happening. In terms of, we don't have a member of Swansea Bay on the steering group. We'll take that away and again have a conversation about that at the steering group, but certainly I'm making sure that I keep my counterpart in Swansea up to date with progress and any issues, and asking her to identify to me if there are any challenges being received since we've closed it in terms of activity. I've not had anything flagged so far. And then in terms of the GP issue, the update this morning from the Command and System Group is they've not seen any impact in primary care so far from the change in terms of increased demand or capacity. So there is a question that's being posed to me based on the data we've got so far, which is there are less people attending Prince Philip Minor Injuries Unit in November than there were in September, October. So I'm interested to understand where they have been redirected to or where they're getting support from, because we're not seeing the impact in Glencree, we're not hearing the report of issue in Swansea, and we're not seeing any direct impact on our sort of daytime general practice services either. So whether they're seeking support from 111 or other means and from other community sources, we don't know. So that's something we've asked this operational team to kind of try and get under the skin of once we've got to the end of the month and we've got a better idea on the final position.
Great, okay, thank you. And then I'm going to come to Lee for final comment on planning resource.
Thank you, Chair. And just on the Swansea Bay point, just to reassure that obviously we have our regular planning operational meetings with Swansea Bay through the art structure, and we have picked up Prince Philip MIU routinely through that, and Andrew was away for the last meeting, but his counterpart has confirmed that they've not identified any impact to date. Now, obviously, we're going to need to test that through the data, but certainly that's the anecdotal feedback at this point. So I think the executive alignment is there. I think there's a question for us to pick up as to whether there's some more operational input required into the options development process in particular. So just on the planning point, I think clearly just in the agenda we've discussed today, the strategic refresh, the clinical services plan, the annual plan, there is an incredible amount of work going on at the moment around planning strategy, which is a good thing. That's where we want to be, but clearly presents a challenge for my team, which is a very live discussion for us at the moment, where we're going to need to be taking a view on that probably in the new year, when we look at how all these things fit together and how best to respond to that. In the interim, obviously in the very short term, it's difficult to do much other than try and prioritise around the key projects. But it is a very live risk for us at the moment, and it is on a risk register.
Right. Okay. Thank you. Okay. In terms of pulling the item to a close, Andrew, you will kind of think further about the membership of those groups to see whether or not, as Michael suggested, we might broaden that. The transport one seems particularly attractive to me as an option. That would be very helpful. Thank you for that assurance, Lee. We're conscious it will be challenging to be able to provide all of those planning services to all the areas that we've identified this morning. The other issue for me is we need to stay close to this, so I think it's through Strategic Development and Operational Delivery Committee that I think this will be gripped, and then come back to the board at the appropriate time with the next stages and developments in terms of taking this work forward. Is everybody comfortable with that? Great, okay, let's agree that. Fine, thank you very much. Briefly, before we break for lunch, can we just cover item 3.9, which is property leases? Lee.
Thank you, Gareth. The paper is self-explanatory and hopefully fairly straightforward, but we clearly need board approval, before we proceed with the leases. So I'm happy to take any questions.
Questions, colleagues? Everybody comfortable with the leases? Yes,
sorry,
please.
Chair, a couple of questions, I'm afraid.
That's fine.
Where are we? There's in terms of the renal leases, up until now, Swansea Bay have been picking up costs associated with that. Do we have a guarantee that they will continue to do so if we renew the leases. I can't see any option but renew the leases because we need to continue to deliver those crucial services. And secondly, on the tidal surgery and dialo, the service charge, we've got assurances for the first year. What about subsequent years? Are there any limits as to the increases that they can impose on us in terms of those lease terms?
Great, okay. Thank you, Maynard. Lee.
Okay, so on the renal, it's yes, it's a national service, and it's a pass-through arrangement. We just have to be the organisation to handle the lease, so it's pretty straightforward. So we're not anticipating any risks around that. I must admit, I'm not sure the answer to the second question around what happens after year one. I guess I don't know if Jill knows the specific answer to the question. The service charge being capped in the first year. I think obviously we've got an ongoing relationship with them, so it'll be based usually on the actual costs incurred with things like energy usage and maintenance like that. So we'll have a means of testing what the costs are, but I don't think we've got any cap on that at this point.
Jill, did you want to add anything to that?
No, I don't. But I can come back to Maynard on that point anyway.
Okay, fine. Well, let's work on the basis of just receiving that assurance. And on that base of assurance with regard to being able to manage the cost of that, because you are right, we could take the lid off on this issue. But if everybody's comfortable with that, then we endorse and agree these lease agreements. Yep. Great, okay. Fine. Can I suggest we break for lunch? Thank you very much. which is led by Sharon, who's going to talk about the annual presentation of nurse staffing levels for wards covered under Section 25B of the Nurse Staffing Levels Wales Act. Yes, please.
Diolch, Cadeirydd. Thank you. Apologies, my computer's just frozen, so I'm going back to the old-fashioned method of reporting. Oh, that's fine. No, fine. So this report is the annual presentation to the board, the calculation of the nurse staffing levels. It includes the spring cycle and it also includes the autumn cycle as well. And I'm asking the board to receive the report that's detailed in Appendix 1, which contains the details of the nurse staffing levels for Section 25B wards across the health boards, namely all acute, adult, medical and surgical inpatient wards and paediatric inpatient wards as well. I know that the board will have had the opportunity to read the papers, and therefore I'll just pull out a few highlights, if I may, Chair. If I go to page 3, Table 1, which summarises the financial and the workforce implications of the calculation cycle that we undertook this year. And in relation to the impact on staffing, the spring cycle, there is a requirement for an additional there's a requirement for an additional 0.32 whole-time equivalent band 5 registered nurses for adult inpatient wards. And there's an additional requirement for 9.27 healthcare support workers. When you break this down, it relates to the number of staff who are working long days. So 0.32 of the band 5 is the nurses that work a long day shift pattern, which has decreased during these cycles. And similarly for the healthcare support workers, that has also decreased as well, which means that we need a higher whole-time equivalent in order to cover those. And that fluctuates from cycle to cycle and essentially is a consequence of staff choice, but also there are occasions when we have younger people working within the organisation and they're unable to work the longer shifts, and therefore we have to make sure that we comply with those requirements.
Can I just ask, is there a pattern?
There hasn't been a pattern, but what we've done this year going forward is we've asked the operational teams to hold back 0.8 within their budgets, so that will then accommodate that fluctuation going forward. So we're not in a position where we have to find additional resource or take resource away on a year-by-year basis. That'll give us a little bit more stability in that space. And you can see that there was also an additional requirement as well for additional healthcare support workers in Glangwili Hospital, one on Pardon Ward and Steffan Ward. And when I do the calculations as the designated person, we use a triangulated approach. So I take into account quality indicators like falls, pressure damage, medication errors. I also look at healthcare-associated infections as well. I also take into account patient acuity, which we measure using Welsh levels of care across the system, and also take into account professional judgment as well. And based on increased patient acuity in terms of healthcare support worker acuity, we've been required to add in additional staffing for Padan and Steffan. So we had a conversation at our business exec team meeting in November. We have been making sure that we comply with the requirements of the Act and therefore have been using variable pay for those. And we will continue to do that based on the conversation that we had, in that when you look at the patients within the system, a number of them are medically optimised. So there's an opportunity for us to look at some workforce modelling going forward and determine whether those patients are in the right place and whether we can improve optimum flow through the system. So at the moment we have not transacted the funding permanently into the budgets, but we are making sure that we provide the adequate staffing by using bank variable pay in that space. So that work is progressing at the moment. I'll stop there, Chair, if I may, and then I'm happy to take any questions or any discussion that you may want to have.
Thank you, Sharon. Very helpful. Colleagues, questions or comments? Are we assured? We are? Great. Thank you very much.
Thank you, Chair. Apologies for the technology.
Absolutely no problem. Okay. Can I take us to our next paper, which is the annual report, Director of Public Health annual report, Their Health, Our Future, Children and Young People's Health and Wellbeing in Hawdd Ar. Adriana.
Diolch, Cardiff. Thank you very much. I'm delighted to be presenting my annual Director of Public Health report this year. I have not printed copies, aiming to be sustainable with the values of our health board, but you should all have in the pack. I have chosen to focus my Director of Public Health report this year in the issues surrounding the health and well-being of children and young people. Being just over a year in post, we've spent a lot of time as a board, but equally in the partnership boards, talking about the health of very important issues around the aspects of our older population, and we have spent, in my opinion, less time that we have focused on what is, as I've titled the report, Their Health, Our Future, deliberately, not because not just because those young people will very soon, as we are talking about 10-year strategy for our health board, will very soon be us, but it is because the society that values, that invests, that promotes the health and well-being of children and young people are healthier societies. I would like to start by thanking, firstly, my team who have worked hard in translating my concerns, my vision, the points that I've wanted to make into the report, which hopefully you'll find a good read and a coherent report. I also like to thank colleagues right across the health board that I've engaged over the past few months in hearing from our clinical teams, from our clinical leads from the pediatrics and pediatric communities, engaging with colleagues across the local authorities, directors of education, in hearing their views about the issues of children and young people. But mostly I would like to thank many families, many children and young people who have engaged during the production of this report in focus group and in interviews and presenting what they think are important issues, equally presenting their hope and what they think or their opportunities for improving the health and well-being in our region are. I will not talk through the report. You hopefully will have read and will have opportunity to indulge and read more on the issues that are highlighted there. I just wanted to pick a few issues that I thought are really pertinent for us as a board to be astute that they are real issues for our children and young people. And I wanted, of course, to pick on a few celebrations, really, on the really good initiatives and on really good examples that our services are engaging with children and young people in our region. It highlights some of the factors that we really find significant that result on issues for our health services, are not necessarily created by health services. Those are issues that then we will need to deal with. I've highlighted in the foreword that some of the most impactful factors that really have direct consequences for health and well-being are formed at very early stages of children and young people. By the age of 5, the number of words that a child speaks is one of the strongest determinants of the health and well-being, and those are translated in our population in terms of health inequalities that we see. 10-year gap in healthy life expectancy amongst our communities, meaning 10 years that our individuals from our communities spend in poorer health, in a lot more demand for our health services, and generally poorer well-being, but also contributions to our society. Some of the examples of really good celebrations that are really having tangible impact are the Tavernpike and Templeton Primary School mental health and emotional well-being, really focusing on inclusion and participation of children and young people, winning a national award as a health promoting school. The East Colborough Pedder, again in emotional health and mental health well-being, pupils themselves creating what they thought are important things for them, 35 different clubs outside the school, including the children that suffer from adverse childhood experiences, engaging in water activities that are really accessible for our communities. I'll end there with the hope that you will find an enjoyable reading of the report, but also that you will endorse the recommendations and embrace the spirit of my report, which is calling upon us to create systems, structures, services that will help enable and empower our children and young people to build a better health and well-being. Diolch yn fawr. Thank you.
Thank you very much, Adriana. Jill and then Delith.
Thank you. I just wanted to say thank you to Ardiana and the team for a very comprehensive report, and I think it's really helpful to concentrate on children and young people actually at this time. We so often talk about our older age population or adults, and I think, as you say, these are the adults of the future. I think, as we've talked earlier, when we were talking about the refresh of our strategy, we have to consider the needs of children and young people, but also we need to be thinking about our partner organisations and the fact that this isn't all about the provision of the NHS or the services that we provide, but very much working in partnership with our local authorities and our communities to make sure that we've got that best future possible. And finding more, I think, and we found this when we went out to the engagement events around our strategic primary and community services plan. It's really important that we go where children are to get their views and to make sure that they do help to inform our plans going forward. But I thought it was a really well set out plan, Ardiana, so thank you.
Thank you. Thanks, Jill. Yes, absolutely. The health and well-being is a partnership. It's a system, as I say, and I have set out in the SBAR that some of the recommendations will need to be driven as a partnership work and will need to be monitored and delivered against as partnership. But, yeah.
Thank you. Delith.
Diolch, Cadeirydd, and Jill has nearly said what I was going to say, so I don't know, the vibes were across the room. I think it's really pertinent and wonderful to see this annual report here focusing on children and young people. Maen nhw yw dyfodol ni, so it's just has to be really focused on their work. Jill has asked the questions I was going to say, but there is one question about data and about evidence-based approaches to working with children and young people, and I'd be interested to see if you are measuring qualitative data as well as quantitative, because I can see there's a lot of partnership in action, but I'd like to see if some of the programmes are research and evidence-based approaches, and then also another question about the true involvement of children and young people in developing service that they want, not that we think that they want, that they want.
Thank you. Thank you for the complimentary words, Diolch yn fawr, Delith. So the first point on the using the partnership, I think it's done. Yes, it is a partnership approach, and it has to be a very strong partnership approach. Using the data and the evidence, quantitative, yes, absolutely. Qualitative, that is why I have chosen to present the report with so many quotes, so many examples, so many a description of the initiatives by the children and young people themselves. So as I said when I introduced the report, we have undertaken, specifically for the report, the team have undertaken interviews and focus groups, but we do have also qualitative, regular data sets that we use in informing really our services and initiatives, as I talked about, the healthier schools, the healthier preschools, whole school approach to emotional and mental well-being. We've got the local authority youth councils, each 3 of us that we engage regularly, so my Children Young People's team. There is the local authority Children Young People survey that does have qualitative questions. And then from the quantitative, there are a whole set of data that we use. I think again, from the conversations with my clinical colleagues, the research certainly in quantitative outcomes, but also in qualitative approaches in how we as a health board with our partners engage and undertake research in children, young people is not comparative to what we do with adults, and we need to improve there.
Can I come back on that as well? Because I think that is key in driving the agenda forward. But you've also illustrated that a lot of these approaches are school-based. We have got a cohort of children, young people that are not in school or not in education. So I'm just wondering if there is another element of this early intervention and preventative work that really needs to target those individual children, young people that are at higher risk.
Very good point. And we have the highest rate of children that are not in mainstream education in Wales, that are generally home taught. That is why I also talk about the asset-based approach with our communities. A lot of the work that we do is through schools and preschools, but it is also with communities, and that is why it's very important. In our immunization rates, for instance, we know, and we've engaged with local authorities even in the last 6 months to get the lists of children that are home taught. There are obstacles there that we need to overcome, but we do need to find better ways of engaging. There are also families of which children and young people belong that are engaged with a different, what we call in medicine, alternative, but also in education with alternative ways of education. We need to engage much better. They are part of our community, and we need to do better there.
Thank you. Anna.
Thanks, Chair. Just to echo colleagues, thanks for the clarity of the report and the focus on children and young people, many of whom still continue to be affected by the COVID years of isolation in all sorts of different senses, so great to see that. I think, we spend quite a lot of time talking about our ambitions for a social model of health, and if we're serious about that, then we need to think hard about what agenda time we give to these kinds of conversations about working upstream. And if we look at our agendas, they are typically dominated by day-to-day clinical service delivery. So I very much hope this might be a catalyst for us reflecting on whether we need to make some adjustments in terms of the proportion of agenda time we spend on these longer-term issues compared with the day-to-day stuff that goes on in clinical service delivery. But I wonder if I might ask a specific question, which is around accountability for delivery of the recommendations and where they might be followed and tracked. And if that's something that sits with us as a lead organisation amongst our partners, whether there may be a role on behalf of the board for one or more of the assurance committees to take some responsibility in overseeing progress against recommendations.
Thank you, Anna. The second part, because I think the first part you articulated, and I think we all agree in spirit that we want to spend more time talking about the upstream issues, about community strengthening, about enabling that they take accountability for improving health and well-being, but we do spend not proportionate time on that. So I think that point you made well, and I know that we all agree. On the latter, your specific question on accountability, on monitoring and supporting the delivery of the recommendations, I think that would be a right approach, that probably the Strategic Development Committee with the envisaged changes, but I think it still remains the appropriate committee, but also the Quality and Safety Committee will be probably the appropriate committee to take some of the recommendations that will need to be monitored and or providing assurance over time. These are not recommendations that I anticipate that will be delivered over the next year. These are recommendations that I hope that we as a region and as a whole society in Hywel Dda will move towards at a stronger and a faster pace, at a stronger effort and a faster pace over the next many years. Diolch.
Okay. I mean, I think your question is very pertinent. I'll come to you now, Michael. I think your question is pertinent in terms of where does it lodge in the committee structure, and clearly, strategic development and operational delivery is currently where it would sit. But I do wonder whether a lot of the delivery of this is not within our gift, or back to that issue, what's in our control, what's not in our control, what we're personally responsible for, what's the system responsibility. So there's a question for me about, it's quite hard in that committee, even though we're migrating to a strategic and planning kind of committee, it's quite hard to really engage with the fullness of the debate around young people and public health or health more generally inside that space. I do wonder whether intellectually we're giving it enough committee time, you know. It might be something we want to think about. We are obviously evolving the committee structure, but it's something I feel as if we need to invest a lot more time and energy in, even if it's just broadening our understanding and awareness and how it needs to be mainstreamed into the whole work of
Agree, and I'll be keen, and again back to why I have chosen to focus on children and young people, that I want to profile that situation and to embed more and stronger in what we do. I think as part of the accountability, as talked, yes, Regional Partnership Board, and Michael is here as a co-chair with me of the Children and Young People Board, will have to support and ensure that we sort of deliver and monitor those recommendations. But as a committee, I think that we need, as a board committee, I think we need to broaden the remit and what we look at strategically.
Yeah, completely. Did you want to come in, or I'm going to go to Michael?
Well, that Michael.
Thanks, Joe. Yeah, I just wanted to politely push back on Adriana on the answer to the second part of Anna's question, which is the tracking bit of it, because I'm totally behind this. You know, what you're trying to do, and children, I think, is the great focus. But if in a year's time I'm sitting here and you have your next report, how do I get any sense of the dial shifting? I appreciate it's long term, but I would say it would be useful to have even the lowest hanging fruit tracking of some sort, just to see the direction of travel is the right direction. I know that's easier said than done, but that's something which would be very helpful, I would suggest. Yeah.
I completely agree. I did not intend to maybe infer or explicitly say that nothing can be delivered in a year. I think my colleagues here, certainly my exec colleagues, know that I often interfere and say that public health is about the long term, but it's not just about long term. Prevention is about long term, but it's not just about long term recommendations. Definitely, we've got a part of the Health Improvement Strategic Plan has got a section on children, young people, in which the annual and the 3-year, that was a 3-year strategic report. Part of these recommendations will go into that strategic plan to refresh the actions that we need to deliver. As part of the directorate and the governances that they have, the directorate will be monitored, but point absolutely taken. It's not all about 20 years. We should see progress year on year.
Assured?
Yes, thank you, yes.
Okay. The two comments, and then I'm going to pull the item to a close.
Very briefly, I was with some of the team last week who would deliver the mental health support to new mothers. The mothers there couldn't praise them enough. They were delighted. What they were sorry about was that they hadn't been able to access mental health support before they became pregnant or they became mothers. And my question is, how joined up is the maternity mental health with the rest of mental health? And I just wanted to add a comment. I think it's a great report, and there's some fabulous facts and figures, interesting and worrying ones in there. They're not about a strategic conversation, but it's good to see them. So it's the join up across mental health I'm interested in, because we're an integrated system.
Yes, good point. And I would make also the jointness on maternity, but also at the other end. And I have made, I think, in my view, a clear point on the jointness and the transition of young people into adulthood. Mental health, I think we've achieved a good joining up of overall mental health in maternity services, for instance, with some of the preventative services, as talked on the report with smoking in maternity smoking. We'll take that point out and we'll consider with colleagues how we should deliver that.
Thank you. Andrew, and then I'll come to...
Sorry, it was just on that specific point, just to reassure, we do have, within the Health Board, we do have a Children and Young People working group, which has pulled together the different services across the different directorates. I think what that has done is it has helped join up teams that were in different parts of the organisation before into a single conversation. I think we've seen some benefit from that, but there's undoubtedly more we can do. And I think as we work through, once I get through the first phase of the OCP and I start thinking about the next levels down, there is some realignment probably of some services that might be supported, that might support all of this in that space as well. Just about that, sorry.
Good, great, thank you. Phil.
Diolch Cadeirydd. Thank you, Diana, as well. It's a really interesting report. I agree, lots of really interesting facts and figures, and the recommendations. I think it's great that we got to focus on children, younger people. I think it does align to the more social model health and well-being, and I agree we don't spend enough time. We need to tilt our agenda. I suppose with the recommendations, I think we would need to consider a number of things with them. So how would we measure success? Some of them might be more obvious than others, some of them less obvious. And I suppose that we would need, I think you suggested, there needs to be a plan behind each of them. Some of them might be a single issue, some of them might be absolutely multifactorial, multitude of things we might want to do to support that recommendation. And we might need to prioritise within all of that. So I suppose within as it is, that's where we are at the moment, the recommendations, but we would need all of that work, the measurement, the plan, the timelines, because otherwise I don't think we could do what Anna and Michael asked, sort of measure progress against it. We couldn't be sure where we would be in a year. And the other thing, I think the point that I think you made, Chair, was around the partnerships, and that we need to consider behind those recommendations. So all of them are partnership. They're at least all partnership with the communities. So they're probably all partnerships with other agencies. And it's how much they're owned by the Public Service Board. I appreciate you presenting your report here, but of course the Public Service Boards and the RPB would need to own them as well. So I guess what I suppose we're signalling is this is the start, which is a good start, but there's work to be done.
Very briefly, because I'm conscious of time. I was looking at my screen because I was sure that in the S-bar I've put something around that there will be action plans and or work groups or existing or newly formed that will need to see to deliver more around those recommendations. This is where the Health Board, where I present and ask for the endorsement of the report, and then there will be the PSBs, the RPB, the Children Young People group that Andrew talked about, I think I agree with you that it's a start, and it's not just the start. Of course, the work has been going on, but I think for me it's a start to highlighting and hopefully profiling in a way that draws more attention and builds more momentum to improving those issues.
Good. Very good. Okay.
Excellent.
Thank you, Adriana. We are endorsing your endorsement of these recommendations, so it's a great it's a great place to continue the challenge of meeting these needs, and we look forward to kind of hearing how that work progresses, both within committee but also at board as well.
Great, thank you.
Great. Diolch. Can I move us to item 6.1, which is primary care governance? Jill, I'm going to hand over to you.
Yes, thank you, Chair. I think we'd agreed at a previous board that we would take a look at matters relating to primary care governance to make sure that, along with the rest of our board governance, things were appropriate and able to provide the board assurance that we had the right systems and processes in place. So I'd like to thank Jo and the corporate governance team for her support in the work to date around this. Now, the first part of the paper really sets out that there are mechanisms in place which hopefully the board members will recognise in terms of strategy planning and quality and safety. We have identified a few gaps, however, and the first one that I draw the board's attention to is the professional performers issues. So there are regulations, NHS Wales regulations, performers list regulations 2004, which we do operate. So there are operational processes in place whereby those arrangements are conducted. But what we have got probably is a gap in terms of reporting that to the board. So we previously had taken some of those reports into an in-committee board, and in conversation with the corporate governance team would seek to rectify that going forward. One of the other areas whereby we've identified that we do need to look at an improvement in terms of the board assurance and reporting process also relates to the contractual regulations or the legal mechanisms. We've got an operational committee, a primary care contract review group, which is a very, very busy committee with lots of decisions that do get made to support the operational business of our contracts across the 4 contractor professions. But with the disestablishment of a group called the Primary Care Applications Committee, which used to be a formal committee of the board some years ago, there's perhaps a gap again that we've identified in being able to provide the board the appropriate assurance and understanding of some of that work going forward. So again, we're looking at how we might do that more effectively, and that may include, for board members who are newer to some of these arrangements, more information coming through board seminars, for example, but also thinking about those opportunities where we do need a formal mechanism to go through to the board. There are 2 elements of that contractual process which we have had to utilise in terms of board decision making in recent months, and they particularly relate to the vacant practice panel process and the branch surgery process. And in the first one, the vacant practice panel process, we have, and with the branch surgery process, put forward terms of reference to support the board decision making, which we would want to formalise and seek board assurance for today. We recognise from the vacant practice panel process that it does rely on a good guide to practice, which is some 18 years old now. And we know that when that was first established in 2006, we were 22 local health boards, very different establishment. They were not integrated boards. But the importance of the fact that it is the board which makes the decision in terms of the configuration of our primary care medical services does need to be supported by the appropriate engagement from stakeholders in our communities. And I referred very early on in our conversation this morning that we had reflection back to us as part of the process we went through for St David's, that community component needs to be properly recognised and established. And I didn't want this to be just about the St David's situation today, because clearly it's a process that we will possibly have to use in many situations. But I know that there was particular concern that there is a recommendation perhaps in the papers around members that we may wish to include within the membership of that panel. And I think by bringing it to the board today, there's sufficient flexibility in the membership, and I've checked this with my corporate governance colleagues, that would allow us to be flexible around that membership and not needing to come back to board for that approval, should we wish to do that. But we did need to set out what the core membership would look like for the terms of reference today. So I'm happy that we discuss that in terms of whether that provides sufficient assurance to the board that that mechanism would be in place, and give confidence to our community as well that they were appropriately involved in that process. So I'm not going to go into a lot more detail. The terms of reference for the vacant practice panel process and the branch surgery process are there for board consideration. We have decided with our corporate governance colleagues that these would not be set up as formal panels on a standing basis, but they would be established as and when we need them for making those decisions. My reflection, and I hope it is the board's reflection, was that it is a very comprehensive process that we enact when we undertake that process. And of course, there is a defined short time scale within which we have to act to enable that, to ensure that our statutory responsibility to provide general medical services is in place within the 6-month time scale that we're given. So there's a lot to do within that time scale, but it has to be informed by our community, by our stakeholders. So the terms of reference are here today for board consideration, but also the wider reference, I think, to the primary care governance processes which we've brought out in this paper. Thank you.
Thank you, Jill. Yep.
So just to support Jill on the point that's been raised rightly by a member of the public, the terms of reference do state, as Jill said, and I just wanted to reiterate that point, that the panels can co-opt any members at any point to be on those panels. So even though you've got your core membership, there is the opportunity is there for whichever panel that's in whichever area, you have that ability there to do that. So that's why Jill's point at the beginning was clear, that this doesn't preclude, if you approve these, it doesn't preclude you adding additional members in as we go along, Chair, because there is a slight risk at the moment. We haven't got up-to-date terms of reference, but appreciate we may want to consider the feedback that's been provided by some members of the public, Chair.
Great, okay. Colleagues, thoughts or questions, observations? Yes, please, Anne.
Thank you, Jill. One of my questions is, on the vacancy panels, is there any workforce representative? You have a practice nurse, but is it, are you co-opting workforce, or are they going to be part of the statutory panel, or trade union, or some sort of staff representation in this going forward?
Yeah, certainly in the engagement process, we would expect workforce engagement to be key, because when we're going through any such change, clearly the workforce and the staffing is important, and also thinking about the workforce model. So from an operational process in undertaking the work around that, we certainly do engage with our workforce teams, but there isn't specific reference, as you've rightly pointed out, Anne, for workforce on that. And here we're talking about independent contractors, so this isn't about staff who are employed, it's about the model for independent contractors, but the workforce element of that is absolutely key. So it's something that we can think about if we feel that there is a specific issue, again, in that flexibility around the membership that we would want to bring in. But I do want to emphasise that when we have gone through such a change as we did around St David's, working with our workforce team and our OD team in terms of that transition process, assisting us with all of the issues around things such as to pay and thinking about the staffing models that we need, and is done very, very closely with our workforce representatives.
Thank you very much.
Thank you.
Thank you. Thank you, Anne. Other questions? I mean, I'm conscious we've had a question or observation from a member of the public who's, I think, the thrust of that question is largely to be assured that the panels and the processes are open to that wider community engagement and involvement at that point. And I think what you're suggesting, Joe, is that that there is the flexibility in the design of those panels to bring in that insight and local expertise into these circumstances.
Absolutely, as Chair, yes, and we'd work with CLICE as well through that process I know Donna's gone, but we always factor that in, Chair. Sorry, I've done what I've asked him, hasn't it?
And one other point I'd really like to emphasise, I think, in 2006, we didn't have the technology or the same systems of engagement that we've got now. And I think if we reflect back on our recent experience around St David's, we actually already had a working group established working with the community around the future model. So, and there was local authority representation, town council and city council representation, as well as staff from the health board. We then undertook an engagement event with the public. We had over 500 individuals turn up at that event. We had over 1,000 questionnaires and the analysis that we brought to that. We had some separate engagement groups where we felt that they may have been affected from inequalities impact perspective. So the opportunities are very different, and maybe the guidance hasn't caught up. But I think the member of the public was specifically concerned around the group that may inform the recommendation. And I think we need to just stress that it's the operational group that helps us develop that recommendation. So we'll be open to look at that flexibly, but it will be the board ultimately that makes the decision and has to question that we followed that process correctly and that we've got that right level of engagement and that we have had that discussion and involvement with our community. So I would hope that there are also the checks and balances at every stage of that before the board does make the decision on the basis of the work that's been done to get to that point.
I mean, I think that's a good summation of where we're at, and I think as a board, what we would be looking for is assurance that that process has been completely democratised, and that the community's had an opportunity to engage proactively and co-productively in the development of that plan or the way in which we move forward. I think that feels really important, yes. Partly for our credibility, and also because it helps to build trust with those communities, which is vital to us working successfully together.
Absolutely, thank you.
Great. Yes.
It's probably just a point of detail on this point. I've just was examining this point, because when you look at the Welsh Health Circular, it just happens to describe there's a particular line that talks about the ability to get advice from or get input from local councillors or public representatives. And when you look at our quorum and attendance, and this may be what the member of public is suggesting, that line isn't in our quorum and attendance. So we just may want to recommend that we just check that both are consistent
within the terms of
within our terms of reference compared to the terms of reference of the Welsh Health Circular.
I think that's a good idea.
Just to check, and it might be I'm just checking on this quickly.
Yeah, it's probably nuanced really, and as Jill's already said, the Welsh Health Circular is just guidance, and the way we do it is exactly how Jill's described through the engagement stage. And we do say we can co-opt any members, which could be anybody on the list of those on Welsh Health Circular. But if you want me to relook at the words, then I can pick up with Jill outside of that, Chair.
That would be helpful. Let's just check the words of that to ensure that what we're doing is offering encouragement and engagement and inclusion. Absolutely. Inclusion in that process. Yeah. I think that would be helpful. Subject to that review, I would suggest we accept the terms of reference if people are comfortable and endorse the terms of references in both cases. Yeah. Thank you, Jill. Great. Okay. Can I move us on to item 6.2? This is the report of the Audit and Risk Assurance Committee. Yeah, so obviously Rodri's not here, and Winston's going to take the item. Winston.
Yeah, Chair. Thank you, Chair. In absence of Rodri, I'm Vice Chair of the Audit Committee, so I'm just going to take this item. There are no items for the board to be alerted to from the Audit and Risk Assurance Committee. It took place on the 15th of October, and just wish to bring out a couple of items for the board to be aware of. First of all, the Audit and Risk Committee continues to look at the board's escalation status with regard to targeted intervention. We're particularly focused on the governance arrangements in that way, and I think the report highlights that we're looking in particular at the arrangements by which directorates are responding to the government's concerns that they wish to have. I think the Audit Committee is looking for more consistency across the Health Board in that regard.
In terms of the escalation arrangements?
Yeah, escalation and how they're responding, because I think, as the report explains, different directors are responding in different ways to it, and I think earlier in this meeting, we highlighted the Mental Health and Learning Disabilities Directorate in particular, where we would have wanted a more faster, more responsive response, whereas other directors are responding a bit more proactively. The other area I just want to bring to the Board's attention is in relation to an internal audit report on falls management, and that does link to the IPAR performance report we saw earlier. We didn't talk about it earlier in the meeting, but if you noted, in October 2024 we had 212 falls at the Health Board, and this report, in particular from internal audit, looked at the falls and how we're doing falls management, but also there were some recommendations still outstanding. And in fact, we received, I think it was a presentation from the falls lead, and there were still some items to pick up on. But certainly, it's a concern that we're just bringing to the attention of the Board. In relation to areas of assurance, we received and reviewed the scheme of delegation, so we're going to be asking for the Board to approve the scheme of delegation. I don't know, Joe, whether at this point you want to make any reference to any additional items of the scheme of delegation that we covered.
It's just to add, Chair, that we've done a full review of this scheme of delegation and we've actually mapped it back right to job descriptions and various other areas. There may be changes now with the new Chief Exec in terms of portfolios, but it's as up to date as it can be at this point. So we Audit Committee has reviewed in detail, so we just seek Board ratification, Chair.
Great. Okay. Two thoughts. One is the kind of endorsement of the scheme of delegation, which I think, even though it's been approved by our Act, we will need to approve. And secondly, just I have a slight anxiety in my head about the undischarged recommendations that are coming through into ARAC, and which have a consequence for patients. We do need to ensure, we need to absolutely ensure that recommendations are discharged in a timely way across all the audit reports we receive.
I think that's right, and what ARAC does, it does keep a track of all the recommendations and whether they have been discharged. I think in this particular item, it was a follow-up to an audit report that we got, and we just highlighted that not all of the recommendations have been implemented. Actually, what I failed to say is that we have there's a cross-reference over to the chair of QUISEC on this particular item as well.
So in addition to the work of the Audit Committee, the Audit Chair has written out to all exec directors with that exact point, Chair, in terms of ensuring that recommendations are fulfilled as quickly as possibly can be, but also through the escalation process which Hugh chairs, and Hugh's been covering the governance element for me while we've been working on the inquiry, Chair. That's been a focus of those conversations in terms of ensuring those that particularly at level 3 are working on their audits of risk. I can't promise you at this point in time that those are going to de-escalate quickly, because there's some long-standing audits that relate to GIRFT and HIW, which we're now working with those areas in Andrew's team to. We've overpromised on implementation dates in the majority of those, Chair. So there is a piece of work going on, because we have got too many now that have gone past their implementation date, and a lot that have gone 6 months past. So there is a lot of work in progress in the background, Chair. But it's been overseen by ARAC.
Okay. I would like, as the Chair Board, to receive assurance in the future that there is a timescale for the delivery of those audit recommendations, and that ARAC are assured of that in its process. It's quite difficult for us to justify ourselves as an organisation if we're not delivering against core recommendations that have been made by an organisation that is looking at the way in which we discharge our services.
I think that's a point well made, Chair. Well made indeed. And on the positive front, just in terms of the assure side of things, for example, in transforming urgent emergency care, where we had an internal audit on that one, that had come back to the committee a couple of times, and we were more sure that the recommendations had been implemented.
Very good.
So we do follow up on quite a number of areas.
Very good. Okay.
Anyway, I think that summarises all that we covered at the last audit committee.
Okay, thank you, Winston. Well covered off from Bwrd's role. Very good. We've covered the scheme of delegation. You're happy with that?
Just if we approve it, Chair, thank you.
We approve the scheme of delegation. Report of the Quality, Safety and Experience Committee.
Thank you, Chair. I was going to put out 2 issues, but on the strength of that last conversation, I'm going to put out 3 issues. So let's start with the bonus one, and that is under the advised section of my report, bullet point 3. We do refer there to the status report we took around HIW recommendations, and a long list of some very old recommendations that have not yet been closed. And I think committee members were all really quite concerned about the lack of progress on some of those recommendations. Of course, it's not the first time we've seen those, but we did sort of up the scrutiny of those last time round, and I'm expecting when we meet next week to hear an update around the systems that we have in place to make some solid progress on those as a matter of urgency. Second item, to alert the board to, we took an item around upper GI surgery at Withybush and the lack of sustainability in arrangements there. I don't know whether Andrew's in a position to be able to provide any update, because those are very much live conversations going on currently. Otherwise, we will review that when we meet again next week.
Yeah, I can. We were able to appoint a 4th locum through an agency to help shore up the rota, and we've got 17 applications for the NHS locum post that we advertised. So I'm optimistic that we'll be able to do something there short term at least.
Fantastic. And then to finish on a high then, we took an item that was framed around a patient story about our Ceredigion Community SDEC service, which is doing really innovative and exciting things that show us a way forward really in terms of how we might work differently in the future. And it was very well received at committee, and we were interested to follow up and understand more about the outcomes that are being delivered by way of being able to make the case for this becoming the norm. And of course this fits closely with Tregaron changes that we discussed at board last time. But the really good bit of news is that Bianca Oakley, who has a leadership role in this service, was nominated for an RCN award, the Chief Nursing Officer's Award, no less. And a number of us saw her last Thursday evening collect her Runners-Up Award as a recognition of her contribution. So it's excellent news. I know Bianca will be the first to say it's a team effort, and it certainly gives that impression, but they're doing really exciting stuff there, and something to be really proud of in our organisation.
Very good. Well done. Congratulations to Bianca. Right. Okay, thank you. Thank you very much. Can I move us on to report of the Sustainable Resources Committee? And Winston, this is back to you.
There are 2 updates. The first update is the Sustainable Resources Committee on the 22nd of October. And then we had an extraordinary Sustainable Resources Committee on the 14th of November. I think this says October, but it was actually November. So in terms of 22nd of October, the Sustainable Resources Committee continues to alert the board on the financial position of the organisation. We know that we don't currently have a line of sight to get to the £44.8 million control total deficit, although we're expecting to get there for next year. It's not in the current financial year. Again, the SLC looked at the finance targeted intervention update, and so we're getting assurance on all of the plans that we're working towards to get there. I think that's all I wish to highlight, actually, because we've covered a number of this already earlier in the board agenda. In relation to assurance, I just want to add to the board, we did a deep dive into the medicines management and sustainability, and I think the committee were really impressed with the assurance that both primary and secondary care prescribing leaves gave to the committee. It was certainly an area of learning. We quizzed them on not only the quality and effectiveness of primary care, but also preventative measures as well. And I think the committee had pretty good assurance from the leads, and we thanked them personally at the time. The decarbonisation task force group continues to do what it can with the limited resources it does have, and I think that's all I wish to highlight to the board at this stage.
Okay, thank you, Winston. I mean, I think we've had a fairly good airing of the kind of financial position we find ourselves in and sustainability this morning. So I think you can be assured we are alerted to that situation without there being any clear action.
In relation to the extraordinary meeting, which happened on the 14th of November, that was an extraordinary meeting because we picked up on 3 items: the digital cellular pathology business justification case, and the digital transformation strategic partner. Then there were the you might wish to add to those 2 things, and also we wish to highlight to the board the procurement update as well. So over to the finance director.
Okay, I think we're going to come back to those now, as soon as we. But thank you very much for drawing that to our attention. Great. Shall we move to the procurement report? And Hugh, I'm handing over to you.
Great, thank you. So if I start off with the procurement report itself, so there are 3 items there that are for the board's approval, and they're just following the All Wales approach to procurement, but not necessarily because the values would exceed £1 million. They require board approval, but we've been part of an All Wales process on this, so that's for audiology, sterilisation and decontamination, and waste and recycling services. And then I'll come on to the digital partner and CellPath.
Are we happy to approve the award of those contracts?
Yeah.
Great, okay.
Diolch, Cadeirydd. The second item I want to discuss is the Digital Transformation Strategic Partner paper. I'm really pleased and proud to be bringing this to the board. This has been some time in the making and the development, and I'm grateful to colleagues for support in getting us to this place. This will be, I believe, having looked around, the first of its kind in terms of having a whole system transformation partner in place. There are integrated care boards across the border who are looking at this, and other health boards are looking at our approach in this. But I think we have been ploughing our own furrow on this. It gives us a really exciting opportunity. I've probably been managing down our expectations on what we could deliver in digital because we have capacity constraints internally, and we don't have necessarily the headspace to think beyond what we're doing in the here and now. This gives us access to a global organisation who can support us with delivery. That's the important thing. But also give us access to connections and opportunities and frameworks that would be at a global level, and gives us access to thinking at that level that we've not had before. I think in some ways this is the first of what I'd like to see as many strategic partners for the organisation. I think our approach to procurement and our approach to working with industry is too often transactional and not sufficiently strategic. We go to industry, we go to procurement with having thought through what we want to buy, as opposed to co-developing what the answers might be with other parties out with the health board. So I think this is an important test for us in terms of our appetite in doing that. And that could be with global players. It could also be with social enterprises closer to home, depending on what the challenge is and how we want to engage. Coming back to this paper, we followed a robust process on this, and I'm grateful to colleagues who've been part of that process. In particular, Michael was part of the first stage of choosing the shortlist, and Maynard was part of that stage, and then came alongside us into the final interviews where we chose the successful party. This is part of our broader Healthier Mid and West Wales thinking, and is based on our digital plan, digital strategy, which is probably about 3 years old now, so needs refreshing and needs refining now. That would be the next space for us. In terms of the opportunity, all too often I think organisations are thinking about the electronic health record from a secondary care perspective and not thinking about integration as part of a whole system way of thinking. And this allows us the opportunity to support the broader regional plan, particularly thinking about Swansea Bay, but also thinking about our 3 local authority partners and DHCW as critical parts of our infrastructure. The way in which we manage this, so this is a zero commitment contract from our perspective, but has a maximum ceiling of £7.5 million a year over 10 years. So it gives us sufficient latitude and flexibility to engage with our partner. Each time we go to the partner for any support, it will be based on a business case that I will bring through the normal scheme of delegation process. So each business case will have in there identified the support that we need. And in fact, we've already had 2 business cases coming through to the board, one on EPMA and one on flow and EOBS, which will be the first 2 cases that we would want support from the partner to deliver. So there are guardrails to us in using this supplier, but it does come back to, I think Winston made the point earlier on about analog to digital, and this will support that transition. With that, Chair, I'm happy to open it up to discussion with a recommendation that we appoint CGI as our digital transformation partner. Thank you.
Thank you, Hugh. Colleagues, Maynard.
As you'd expect, I have something to say on this. Having been involved in the process, I can vouch for that. It used to be my day job, and I can see that the process that was followed was absolutely robust, fair, and above board. But most importantly, I think this gives us opportunities that we would not have otherwise. Hugh's mentioned a few of them, but having done the day job of managing IT and digital services in a health board, one of the last things you have is space to think about what's the art of the possible. I think having a strategic supplier who's always thinking about what the art of the possible is and supporting you in your thinking is going to be invaluable. Hugh's also mentioned about the opportunities it brings us from a regional basis as well, because this does not restrict us in terms of who else we work with. We will continue working with DHCW on national projects. What it gives us the opportunity is to accelerate the implementation of some of those strategic systems, because we are no longer in the position of having to say, actually, we're going to need to go out to recruitment to get a business change analyst in this particular field, or a particular cyber specialist or whatever, because we can go to our digital partner and say, what can you deliver to support us in this? And I think that when you look at some of the systems that we've got coming, like EPMA, which has got so much backing from clinical background and so on, this will help us to accelerate the implementation of that, things that we are already committed to. So I just want to lend my whole heart support to the actual letting of this contract.
Okay, thank you. I'm not going to take any comments unless people are adversely against this this idea.
I'm not adversely
Well, then,
against that. I just wondered, whether CGI, do they provide something like this in elsewhere? Is it tested?
As a strategic partner to other organisations, yes, but not as a whole system strategic partner. That's the new element for us, I guess, because we are already an integrated health board, and that's where the opportunity is unique for us.
That's right.
I just want to add, Chair, that it was really important that what we tested was that the process for choosing the partner was a robust one, and I think that was really important, because if we're going to be, if you like, working in partnership with CGI over the next 10 years, it's really important that we choose the right partner, and I certainly, as Chair of FSRC, was assured that with the IM involvement and with Hugh and others, that they are the right partners. Obviously, it's going to mean, because we're pioneers in this area, we're going to be watched by Welsh Government, but actually there are many benefits to us in going ahead with this.
Yeah, great.
Actually.
I'm conscious we could have a richer, fuller, longer conversation about this, because it's a great piece of work, Hugh. Well done. And it is innovative, it is pioneering. I would like to think that we can have a conversation at this board about digital capacity and capability and the art of the possible. That would be a fantastic conversation to have for us in the future and help our strategic thinking. So, but time forbids that conversation now, or even the edges of it. Can I suggest we endorse this approach, and thank you for your work on it.
Thank you, Chair. And this will be subject to Welsh Government approval.
Of course.
Naturally.
Of course. Great. Can we move on to digital cellular pathology, BJC?
Yes, thank you, Chair. And I'm speaking on this issue as the lead for digital, but it's a case that's come through the operation and clinical team. Clearly, digital cell pathology is an area that we have got significant challenges at the moment in terms of staffing and provision of service, and this will certainly support the acceleration of the transformation of pathology services and support more innovative and novel ways of working, introducing the opportunity for sharing information across the system, working much more closely with Swansea Bay, but also working much more closely with other organisations nationally. It gives us the opportunity to think quite creatively about the way in which we use staffing across the UK, but also it might allow us to think globally in terms of the opportunity of engaging with pathologists from elsewhere. And it also gives us the infrastructure that a modern healthcare provider should be utilising. There is a case for, the financial case does stack up on it. There may be a slight issue in terms of the timing of the cost for implementation versus the cost versus the benefits that get realised, and I'll work with the Directorate to make sure that that is managed appropriately over the year. But Chair, I think this provides us with the tools that we need to sustain that service going forward.
Okay, great. My only question is the link to Swansea.
Yeah, this is naturally linked across Wales, so it's an all Wales piece of work that's been
Great,
done.
okay. Can I ask if everybody's comfortable, the board, to endorse this? Great, okay. Let's approve and offer our endorsement. Great, okay. Can I move us on then to report of the Strategic Development and Operational Delivery Committee? Maynard.
Thank you, Chair. Not a lot to add to what's already written there. The only thing we wished to alert the board on was cancer performance because of the significant drop reported to SDOD. Andrew's kindly already given us an update of that earlier in the meeting, and progress has been made against that. Other than that, it is, as it's written, the only other thing is that there is a subsequent paper immediately below it supporting the publication of the Wellbeing of Future Generations annual report.
Great, thank you. You are right. We've had a good airing of the cancer figures, and hopefully we will see some improvement as we press ahead. So that's helpful. Are we happy to approve the Future Generations, Wellbeing of the Future Generations annual report? Great, okay, fine. Ardiana, Wellbeing Objectives annual report.
I think that's one that we just approved. I probably would not take much time. I'll just say that it highlights the work that we as a health board do in delivering our 8 objectives around the Wellbeing of Future Generations Act and how we align with our PSBs in delivering those objectives.
Very good. Okay. Chantal, report of the People, Organisational Development and Culture Committee.
Thank you, Chair. We met on the 29th of October, and as you noted, as part and parcel of the paper, there are no items for us to alert or advise the board. And in relation to Assure, just a couple of things to note is that we continue to to oversee the key initiatives for improving workforce sustainability, leadership development and organisational culture as part of the targeted interventions. And also that, it's already been said today around the reduction, the programme that is being done in order to reduce agency and bank nurses. And in relation to anti-racist Wales implementation group, there will be a seminar session which is scheduled for the 12th of December in order to discuss the strategic equality plan. Other than that, everything is as on the report here.
Thank you. Board, do we take assurance from Chantal's update? Great, okay. Anne, report to the Health and Safety Committee.
Thank you, Chair. The Health and Safety Committee met on the 12th of November. There was nothing to alert. To advise, there's limited assurance was received from the analysis of sharp incidents which were reported between 23 and 24. This is being returned and being brought back to reconvene with the new Health and Safety Subcommittee. The next item under alert was the Prince Philip Hospital temporary traffic control issues. That was reported, and that was unable to provide the committee with assurance of the safety of patients and staff due to the current traffic flow going through there. And we're also waiting a response from Carmarthen County Council on the concerns raised by the Health Board, because we hadn't heard anything at the time of the committee. The assurances were on the health and safety terms of reference, which we'll be asking to be approved, the health and safety assessment outcome report, operational risk, health and safety update, reporting on riddle, low voltage. We've done a lot of work on that, and that's being brought up to date really well. And now Boris system's working well as well. And that was in the fire audit and the estates and facilities Welsh memorandums. So the board is asked to approve the Health and Safety Committee terms of reference, please.
So just to support Anne there, the Prince Philip item is advised, not alert, so the board don't need to take action on that at this time. So I just wanted to pick that point up. Sorry, Chair.
Great, okay, thank you. Are we happy to endorse the terms of reference?
Yes.
Yep. Great, thank you, Anne. Delith, report to the Charitable Funds Committee.
Diolch, Cadeirydd. I'll take the report as read. This was the meeting on the 17th of September 24. There is an item for alert. I don't particularly want to go into detail with it because it is a legal issue. However, and it has been appropriately and in detail scrutinised at our Charitable Funds Committee. So there is an item for advice as well in regards the downturn in donations and fundraising activity. This is similar to a number of charities working in this sector. But the issue that I would just like board approval of is to approve the request to issue the proceedings.
Okay, I'm just consulting with our director.
We will be taking it in committee.
This is the alert item?
Yes, it is the alert item.
So just to give clarity, there's a board requirement if we're going to issue proceedings that the board have to approve that and has to approve it in public. The way the report's been written is obviously we can't share any further details in the public domain because it could potentially damage the case. But for assurance, it is on the in-committee report and it has been fully debated at Charitable Funds Committee, and the recommendation is that we do approve because it's in the right interests of our charity to do that, Chair.
Okay, let's endorse and support that decision.
Thank you, Chair.
Great, okay. Can we move on to our next item, committee update reports?
Yes, Chair. So the last report from the committees, this covers the Ethics Panel, Remuneration and Terms of Service Committee, Health Professionals Forum, our Staff Partnership Forum and Stakeholder Reference Group. So that gives you an update from all of those groups and committees. There are no alert matters to raise to your attention as the board. So just for you to receive for information unless there is any specific questions on any of those items, Chair.
Colleagues, any specific questions? No? Great, okay, thank you. We've received them and we've noted. Then let's quickly move to working in partnership. So we've got joint committees and collaboratives. We go to Phil.
Thank you. Diolch, Cadeirydd. So this report gives an update from the various joint committees that we have, Joint Commissioning Committee, the MWSSPC, so the Shared Services, and the Mid Wales Joint Committee. I mean, I think colleagues will have read the papers. The Joint Commissioning Committee is starting to find its feet, I would say. I think the emerts issue has been something for it to grapple with almost immediately as it was formed. One particular issue that we are, as a health board, working with them on is the issue of the land-based service that the Joint Commissioning Committee is working on, but we'll give further updates as we're able to.
Great, okay.
Happy to take any questions on any of the other reports.
No? Great, thank you very much. Then can I take us to statutory partnership updates? Jill.
Yes, thank you, Chair. Very briefly, just to highlight that the Regional Partnership Board has been undergoing a bit of a self-assessment, and we've had 3 workshops facilitated by an external agency. And I think it's really to make sure that the Partnership Board is meeting the expectations, really, or changing expectations of its functions going forward. And I'm sure we'll hear more through our own board in due course. And then the second point I just wanted to raise was that by the time this report was written, there had been the first regional footprint meeting. I understand, Chair, you're part of that, with the Cabinet Secretary. That's a meeting that's happening in every health board area, looking at the priorities and performance against the priorities of the Care Action Committee, and in particular at the moment, our response to the 50-day challenge work.
Indeed, and I think it was winter preparedness was quite a key item on the last agenda. Yeah, thank you very much. We are asked to take assurance and to note the actions which have been completed to date. Are people happy to do that? Yes. Great, thank you very much, Joe. Okay, let's do that. Colleagues, the end of the formal proceedings. Any other business? No? Great, okay, I can feel at the end of a long meeting, it's highly unlikely. The bar for any other business is very high. Great, okay. Thank you very much for your contribution. Some really good papers, some really informed conversations as a consequence of the really good papers. And have a safe journey. Thank you very much indeed.